Okay. Okay. All right, wonderful. So again, welcome to NCSD's first Clinic Plus Connect Community Conference. We're so glad you're here. This is the nation's first and only collaborative dedicated to sexual health clinics. And I really want to be very clear because this is open to anyone who provides sexual health services. So if you do so in an emergency department setting, in a doctor's office, if you do so at a categorical STI clinic, an ASO, a CBO, welcome. You're in the right place and you're among family. So the goal of Clinic Plus is to elevate, uplift, and to support sexual health clinics. As I said, we're here to assess and build capacity for HIV prevention in sexual health clinics, to reinforce and support the essential role of sexual health providers, and we are playing a vital role in ending the HIV epidemic plan in the federal STI action plan. We provide trainings, technical assistance, one-on-one and otherwise, and we also love to connect with people to learn about what you do well. I think there's not a clinic here, there's not anyone on this call who doesn't do something exceptionally well. And what we're doing is building a resource library, a national resource library that will be housed on our website that includes what everyone does well so we can all continue to learn from each other. Part of the Clinic Plus initiative is the Clinical Advisory Council. This is comprised of 16 experts and leaders in the sexual health clinic field. We convene monthly via Zoom, and they advise NCSD on all clinic-focused work. They help us to establish priorities and to enhance the capacity of clinics to provide sexual health services. And you'll see our Clinical Advisory Council members here. And of course, the committee is chaired by Dr. Chris Hall, who works very closely with us here at NCSD. I don't need to tell you how COVID-19 impacted sexual health services. 89% of you reported a decrease in patient volume or total number of clients served as a result of COVID-19, and about 2/3 reported that clinic capacity was reduced. This prompted us and you to think together about innovative solutions on how to continue to provide sexual health services. NCSD pivoted immediately and began hosting weekly Clinic Plus COVID-19 information sharing calls. These were open to absolutely anyone who was working in sexual health. We also created a COVID-19 command center and had a special section specifically for sexual health clinics that included protocols, best practices, and how people were navigating and continuing to provide services during the height of the pandemic. NCSD also published a sexual health clinics in our nation's COVID-19 response, which someone will be adding into the chat very soon here. And what came out of this is a Clinic Plus community. What really formed here is thank you so much. You know, the world is crazy. My job is crazy. Here's 1 hour where I connect with people who understand what I'm going through, the challenges that I'm facing in trying to continue to provide services. And we increased our membership over 2.5 times just over COVID. And we've created this really, really great collaborative of folks who are like-minded, who are trying to continue to provide these essential services. Because as you know, and as David stated, you know, this is the entry point quite frequently for people's integration into the healthcare system at all. You know, sexual health clinics do much, much more than provide just sexual health clinic, you know, testing and services and treatment. This is how people navigate the healthcare system. There are a lot of referrals that happen. A lot of connections happen at sexual health clinics, and we're here to elevate all of that incredible work. So as I stated, programmatic technical assistance is available to all members of Clinic Plus and NCSD. It is completely free to be a member of Clinic Plus. It is completely free to receive programmatic technical assistance. I encourage you, if you have a question, if you just want to connect, please reach out to us in the chat or email us. And again, through Clinic Plus staff, we field clinic-specific requests on topics such as EPT, infrastructure, implementation of programs, quality improvement, uptake. We're currently working on a website redesign that we can organize all of our recorded webinars and tools in one searchable place. Currently, they're in different places on our website, but there are a lot of tools. And we also have a lot of resources that are shared from people like you. So standards of procedures, what's the best way to do this? What is a good intake sheet? What have people found works and what is helpful, as well as EMR modifications. So, hey, I have this EMR. I would love to know, do you know a good way to report this? Do you have any reporting templates? We'd love to talk to you about all of those requests. Something that we've also done is a clinic collective. So we run and we manage communities of practice dedicated to sexual health professionals. So our first collaborative was around PrEP implementation and included 14 participants representing 10 clinics. And they met with us monthly to review different aspects of PrEP implementation in their clinics. Some upcoming work that we're doing. We just completed a Prepared to Support Women and Their Sexual Health webinar series. It was a 3-part series that explored the different components of providing PrEP to women. We also are working on launching a community of practice for new and fledgling sexual health clinics. If you are not a sexual health clinic, but you provide sexual health services, I want you to know that you're still welcome. So if you're an ASO that is starting to do testing, wonderful, you're in the right place. So when I say sexual health clinics, please don't feel that you need to be an established clinic all by yourself in order to qualify. Everyone is welcome here. We're also working on a webinar series on sexual health clinics, component C clinics, around EHE innovations in sexual health clinics that they have achieved, and a webinar series on congenital syphilis. So if you are interested in any of these things or all of these things, please reach out to NCSD staff in the chat box, or you can email us and we'd love to connect you. So another great way to get involved is we host Clinic Plus Connect community calls. They're completely free, they're open to everyone, and they're the third Friday of each month from 1:30 to 2:30 p.m. Eastern. All are welcome. So just to give you an idea of some recent topics, last month we heard from our colleagues in Wisconsin about curbside treatment. So they developed a response to COVID-19 to mitigate exposure, and folks were driving through to receive STD treatments. Pretty innovative. Then the previous month, we heard on perspectives on point of care testing in STI in clinical practice and outreach settings. And we had a group of graduate students from Johns Hopkins who conducted interviews with key stakeholders from across the country to understand some of the considerations around this. And this is really great stuff because this is only important if it helps you. And so if there's something that you do really well and you'd love to be featured on a call, we'd love to have you. Please connect with us and we would love to feature all the hard work that you're doing. So connecting, this sounds great. I'm in, right? How do I connect? You can email me directly to request to be added to the Clinic Plus listserv or to set up an introductory call. We love introductory calls. Even if you don't think you need help with anything, just come say hi. We'd love to hear about you and your clinic and who you serve and how long you've been in the field, just to learn more about you. So just please reach out and we'd love to connect with you. You can also check out the Clinic Plus website. And I encourage you to check out My NCSD. My NCSD is a social networking tool. It's kind of like a Facebook for those in the STD services world. And so basically you can connect with people. There are different posts. There's a lot of information presented, and it's a good way to connect with colleagues across the country around similar questions you may be having or concerns, or, hey, I'm thinking about this. What do you guys think? It's a great way to kind of to connect with a lot of people in a really easy capacity. So that's all I have to you. Again, I'm Jenny. You will meet my colleague, Michael Canty, the Senior Manager of Clinical Programs. And we hope that you enjoy your time today here at the Clinic Plus Conference. I do also want to add that the gift bags for the first 500 people that registered will be shipped out in the next couple weeks, and we will be asking for your address information when we send you the survey about the conference. So you'll be getting more information about that at the end of the conference, and that will come to you in an email. So now, without further ado, we're going to move on in our agenda. We're a little bit early, but we're going to keep going. I'd like to introduce Dr. Laura Bachmann. Dr. Bachmann is Chief Medical Officer and the Acting Deputy Division Director of the CDC Division of STD Prevention. Prior to coming to CDC, Dr. Bachmann was a professor of medicine at Wake Forest University Health Sciences in Winston-Salem, North Carolina, and medical director of the Guilford County Department of Health and Human Services Public Health Division. Dr. Bachmann was the co-director of the CDC-funded Alabama, North Carolina STD Prevention Training Center and has been involved in training healthcare providers for over 20 years. Boarded in internal medicine and infectious diseases, Dr. Bachmann specializes in STD and HIV care with experience practicing in academic and public health settings. She is an expert in the diagnosis and management of STDs, including HIV, and she's performed research addressing a variety of STD/HIV control issues in both clinical and non-clinical settings. Dr. Bachmann's clinical team led the development of CDC's recommendations for providing quality STD clinical services 2020 and the forthcoming 2021 CDC STI treatment guidelines. Dr. Bachmann?
Thank you, Jenny. Can you hear me okay?
Yes, we sure can. Thank you so much.
Okay, and I am sharing my screen now, so hopefully you're seeing one slide up. Thank you to Jenny and David and Chris for asking me to speak with you all today. And they asked me to cover specifically some of the updates that are proposed for chlamydia trachomatis treatment, and that many of you have seen in the context of the MMWR that came out recently for updates to gonorrhea treatment, and also the public comment webinar that we had back in December that covered some of this as well. So I have no disclosures. And while I'm going to focus on chlamydia for a lot of this, I did want to kind of go back to that MMWR and talk about some of the rationale for the changes in the drop of the azithromycin. There's a fair amount of overlap between the rationales for some of the changes with the gonorrhea treatment and then the chlamydia treatment as well. So as many of you know, we published an MMWR December 18th. On updates to gonorrhea treatment, and at that time recommended that treatment should be ceftriaxone 500 milligrams in a single dose, and then for individuals who weighed more than equal to or greater than 150 kilograms, that the dose should be increased to a gram of ceftriaxone. So we increased the ceftriaxone dose. We discontinued the use, the recommendation to use azithromycin with this. And then we put in the bottom of at the box here, if in the MMWR, that if chlamydia has not been excluded, that an individual should also receive doxycycline 100 milligrams twice a day for 7 days. Interestingly, you know, we didn't get a lot of, I mean, we did get feedback on the increase in dose and the changes, but there was a lot of interest around this part of the box where we recommended doxycycline for chlamydia, understandably. So that was like the top question, I think, that came out that we were getting from the field and from partners after we released these recommendations. And because the MMWR, it was a policy note, and the focus was on gonorrhea, and unfortunately there was not a lot of space to get into the rationale for that piece about using doxy for chlamydia. And so understandably there were concerns raised. I think, you know, concerns about adherence was probably the most common concern that we heard. There was concerns about pregnancy status for persons who can become pregnant, and then concerns about side effects. So I'm going to get into some of this, but I'm going to start with you know, some of the lines of evidence that we were working with that led to the decision to remove azithromycin as code therapy for gonorrhea. So I think really probably the number one reason for dropping azithro, and this is not the number one reason for changing chlamydia treatment, but for dropping azithro for gonorrhea treatment, was the impact on the microbiome and co-occurring pathogens. And I'm sure many of you are aware that over the last decade plus, the increasing concern about antimicrobial resistance, antimicrobial stewardship, and then also our knowledge base about the microbiome has continued to grow tremendously, and certainly has grown a lot since the last revision of the guidelines. And just to give an example, this is not the only example, but of the potential impact of treatment on the microbiome. This is a study that was published recently of a randomized controlled trial of, and it was a treatment of children with either placebo or with azithromycin. And the children received azithromycin just a couple of times a year. And then the investigators looked at their, basically their gut resistome. So they sequenced, organisms that were found in the gut, and there was a significant difference in the antibiotic resistance determinants in the children who received azithromycin. And so, and interestingly, it was not just an increase in determinants for macrolide resistance, but also for other resistance to other antibiotics. This group had earlier shown that there was increased colonization or a higher proportion of macrolide resistance in nasopharyngeal strep pneumo amongst communities who received this mass azithromycin distribution. And so just kind of the evidence base, and this is, specifically about azithro. I'm sure it could be other studies with other antibiotics, but the evidence base for this and the impact it just continues to build. And that's just one example of a study there. We also are, worried in particular about MGent and Mycoplasma genitalium. And, there's a lot of concern about this, this STI, which, is tied most tightly to urethritis in men, but also has been associated with cervicitis and with PID in women. And this is a study that we conducted and published in 2020 that looked at the prevalence of 23S rRNA macrolide resistance mutations and also par-C fluoroquinolone resistance mutations in MGent by study site. And this particular study was conducted out of 6 STD clinics in geographically different areas of the United States, and enrolled men presenting with urethritis that was confirmed with a gram stain. And we found that, close to 30% of the men had MGent, and they may have had chlamydia and gonorrhea also, but MGent was detected in close to 30% of these men. And amongst those individuals who had MGent, there was a very high proportion of the 23S rRNA macrolide mutation, and that mutation does correlate pretty well with clinical treatment failure. The par-C mutations or the fluoroquinolone mutations don't correlate as well with treatment failure, but they're also of concern. So you can see that across the board, if you put the blue and the yellow together, that in some case upwards of close to 80% of the men with MGent had macrolide resistance with or without fluoroquinolone resistance. So this is an example of an organism when we know that it does not take exposure to much azithromycin. Actually, it can be just a single dose to induce macrolide resistance in Mycoplasma genitalium. So this is one organism where we see kind of some of the maybe bystander effects of azithromycin. We're also seeing more resistance with enteric pathogens, specifically Campylobacter and Shigella. And these are just examples of case reports that have documented outbreaks, particularly in men who have sex with men who have these enteric organisms and that have resistance to azithromycin. So this is of concern as well. Another line of evidence, and once again, this is specifically to remove azithro as co-therapy for gonorrhea, was the surveillance trends. And historically, this has been the main driver really for changes in gonorrhea treatment. It was important, but perhaps even maybe secondary this time around. But you can see here, these are our GIST surveillance data from 2010 to 2019. And fortunately, cefixime and ceftriaxone susceptibilities, when we look at proportion of isolates and their MICs, those are, stable to even down for cefixime. But you can see in pink here that for azithromycin, that the percentage of isolates with elevated MICs to azithro continues to increase. And it's over 5% in the GIST population. If we look at specific populations, we can see there's even a higher proportion. So this, of course, is also of concern. So now I'm going to get into where we kind of dovetail with the rationale also for chlamydia. So it was, there was the benefit of azithromycin for chlamydia was not as strong also when we considered it due to emerging data on the efficacy of azithromycin for chlamydial infection. And this is specifically even more concerning for rectal infection. So let's go through a little bit of data here. This is a slide that Dr. William Geisler put together and was kind enough to share with me. But this is a compilation of different studies, different methodologies. They include male and female patients, but over time that show this signal, and this is specifically for urogenital chlamydial infection. And you can see doxycycline in blue and azithromycin in green. And while azithromycin efficacy here is still looking pretty strong for most of these studies, you can see that Doxy has an edge here over the azithromycin. Now, if you were to look at symptomatic male urethritis, that signal would be even stronger than it is for the female, some other syndromes that affect women. But, it's just kind of it's a consistent point. And actually, if you were to look back at the studies that were done to demonstrate equivalency of azithromycin to doxycycline, this is reaching back years beyond these particular studies, that signal was actually there too, but it was just not statistically significant. So we've had some concerns about urogenital chlamydial infection, but not quite, they're not statistically significant differences in the majority of these, pretty much all of these studies at this point. But I'm going to take y'all through, before I get into the rectal site, I am a clinician, and so I wanted to take you through a case that I actually worked with when I was in North Carolina that kind of illustrates some of these issues. So this particular individual, she was 21 years old. She presented for routine prenatal care and had one HIV negative partner in the previous 12 months. She had a physical exam at that time based on the notes that I reviewed that was normal except for a friable cervix on pelvic exam. And this is where her saga began. So this is just a compilation of the different dates. I have altered them a bit to just protect, even though there's no identifying information here, but I've altered the dates a bit, but the time frame is the same. And so you can see that, she presented in January, had a friable cervix, and her NAT was positive for chlamydia. She received 1 gram of azithromycin through a prescription. She did go and get that filled. She threw up about 2 hours after taking it. All of her other testing was negative. She came back in right at 4 weeks for a test of cure, which is recommended for chlamydia in the setting of pregnancy. And her chlamydia test was still positive. And so by the time they got that back, they called in another gram of azithromycin, which she took. And at this time, she also gave the feedback that her partner had tested negative for gonorrhea and chlamydia. She presents a month later, and she has her test of cure again, and once again is positive, and this time the specimen's a pap smear test. So this time, they gave her amoxicillin for 7 days, and gave her a suspension at that point, and then brought her in again, and she's positive. And at this point, this is where I meet the patient, and so I'm going to tell you what we did here. Actually, no, sorry. Actually, they gave her 5 days of azithromycin by a prescription. And then at that point, she's positive again, and then I meet the patient. And so she presents to the health department. I had her bring her male partner in, even though they had not had activity, any sexual contact pretty much since she had been diagnosed with the pregnancy. But I had him come in as well in a separate room to talk to him. And on exam, she did have frank mucopus, and I went ahead and did a rectal, because I had some concerns about rectal infection. She did not have a history of any rectal receptive anal sex or anal toy exposure, but I went ahead and checked her rectal site. And she actually had evidence of rectal friability on her swab. When I withdrew the swab, it was there's a little bit of purulence and there was some blood there, and it was not a traumatic swab. So she did have her NAP positive for the cervix and the rectum, and also talked to her a bit, of course, about whether she took her medicines. And while she endorsed taking all of her medications, she actually ended up suggesting that we do directly observe therapy, which I thought was kind of curious. So I did have some question about whether she was getting all of the azithromycin in during the time frame within which she was given it, which can have some relevance for whether or not it would, treat the organism successfully. So we went ahead and did, and this was expert opinion. This is not a CDC recommendation, but a gram a day for 4 days. But I had her come into clinic and do it under observation, take it under observation. The male partner, by the way, was his exam was normal. He was asymptomatic, and his testing was negative. So in July, which was not even, this was within a couple of weeks of when I treated her, she developed delivered a healthy baby only 4 days after completing therapy. We checked a chlamydia NAT was checked, but it was not expected that it would be negative really at that point, even though, because the treatment was so close, and she would at the very least be shedding DNA from or RNA from chlamydia at that point still. And sure enough, it was still positive. Placenta was normal, and we actually sent the specimen because she grew the chlamydia in culture. We sent it to University of Washington, and susceptibility testing was performed, and it was considered susceptible to azithromycin. We did follow-up testing 6 weeks after delivery, and she was negative for chlamydia, and the baby was fine. So that was kind of an extraordinary case, but the question is, how common is this phenomena? I personally hypothesized that her rectal site may have never cleared entirely and could have potentially reseeded the genital site. But I don't know that for sure. That is my hypothesis. So rectal chlamydia in women is not uncommon. In fact, in women who have genital chlamydia, the rectum can be positive in close to 90% of the cases. It depends on the study, but a high prevalence of rectal chlamydial infection. Anal sex history is not predictive of infection. And so it's, we've always thought that women may become infected in the rectal site through autoinoculation, potentially. That's been a long-standing hypothesis for this high prevalence of rectal chlamydia, and also gonorrhea can be quite frequent too. So, and then the kind of the flip side of that is there's been, concern about the potential for a rectal site to then reseed the genital tract. And we don't know for sure how often that happens, or really even for sure that it happens, but there's a biological plausibility for that to take place. So going back to the data again, when we look at rectal chlamydial infection and look at efficacy of Doxy versus azithromycin, once again, we had quite a few studies that demonstrated this difference in efficacy, but as you can see, the difference was quite a bit more dramatic for the rectal site compared to the urogenital site. And once again, these are studies that are all different methodologies over different periods of time. And so we're waiting really on a randomized controlled trial, which we fortunately did receive data for a randomized controlled trial that was presented by Julie Dombrowski at the 2020 STD Prevention Conference. And in this particular study, men who have sex with men with rectal chlamydia were randomized to doxycycline versus azithromycin. The bottom line is, and these different columns demonstrate different ways that they analyze the data, but the bottom line is that the efficacy, there was a clear difference with superiority of the doxycycline to the point where the study was actually terminated early by the DSMB. Just a week or so ago, an Australian group also published in the New England Journal of Medicine a randomized controlled, and this was a blinded trial. So the participants in this study did not know if they received Doxy or azithromycin. And so they also found really similar types of findings here. But the bottom line is that, and no pun intended with that, but that there was a clear difference in efficacy here, whether it was looking at the modified intent to treat analysis or the per protocol analysis. Interestingly, adherence was the same for both groups, and adverse effects actually were a bit more common in those receiving the active azithromycin drug. So this article, I would recommend that you review this, but just to go through some of the explanations this group came up with the difference in efficacy for azithromycin compared to doxycycline. There, from a basic science point of view, the chlamydia minimum inhibitory concentration for azithromycin is 4 times higher in colorectal cell lines compared to endocervical cell lines, whereas doxycycline MIC does not vary by these cell lines. We know from a pharmacokinetic, pharmacodynamic perspective that doxy and azithromycin are both lipid soluble, but azithromycin is transported primarily by inflammatory cells. And there's also some data that show that the inflammatory response to chlamydia may vary by anatomic site, and potentially it's dampened in the rectal site, which if a drug's being transported by the inflammatory cells, it makes sense that maybe the drug levels aren't getting to where they need to be if you're not having a lot of inflammation there. And then finally, there's several different compelling animal studies that demonstrate chlamydia in the intestinal tract is more difficult to clear with azithromycin compared to doxy. And some of these differences are quite dramatic with even in the face of high doses of azithromycin, animals having infection for months and months. So all of this together, these are some of the hypotheses about why we might see differences there. Now, there are understandably concerns about doxycycline adherence. We have for a long time, said that for STD treatment, we want single dose directly observed therapy as a gold standard. And that has not necessarily changed, but when there's differences in drug efficacy, then that affect whether a patient's going to clear the infection, then of course that needs to be taken into consideration strongly. And just to give people a bit of background on the adherence issues with Doxy, there is historic data that demonstrate there is a disconnect between Doxy adherence and treatment failure. I published a study, it's been a while back now, using MIMS caps, and Julie Schachter wrote an editorial for this. It actually was in 1999, let's get the date here. And he wrote an editorial about, what is the minimum effective dose of Doxy for chlamydia? And we really have not defined that. There was a study by Taylor Robinson in 1986 that showed another tetracycline class antibiotic, minocycline, was highly effective for chlamydia. And then in the MIMS cap study that we did, only 16% of these participants took Doxy as we would expect them as providers to take, and that is 100 BID for 7 days. However, the treatment failures were very low, and 6% of those had chlamydia isolated on culture. That were only 6% of those who had chlamydia on culture at enrollment were PCR positive at follow-up. And when we looked at those individuals who had positive PCRs, there was of those who had their MIMS caps that they returned with their pill counts, four of them did not open their bottle for more than 24 hours. So they basically drugged their treatment out for an extended period of time. Also, interestingly, there was a randomized study, and this was an open label study. It was small numbers, published in 1997, that looked at 3 days of doxycycline versus 7 days of doxycycline, and found that they were equivalent. They performed test to cure at 3 weeks. So they both had high efficacy, 94, 95% cure rates. Now, obviously, this is not enough evidence to change how long we prescribe Doxy for, but it does call for the need for additional studies to kind of tease this out, to figure out, how much Doxy do we need to give for chlamydia. So in summary, for this piece of it, in terms of dropping the azithromycin, part of that evidence was based on microbiome impact from relatively little azithromycin. Has been demonstrated now in some large studies. We know that the prevalence of decreased susceptibility to azithro and gonorrhea isolates continues to increase, and we're seeing more resistance, azithro resistance, in potentially co-occurring pathogens like MGent, Shigella, and Campylobacter. However, for the purposes of thinking about chlamydia, it's that superior efficacy of Doxy, most markedly for rectal chlamydia, that really drove the decision making, and that's despite concerns about difference in adherence, and also understanding that we really don't know the minimum number of doses of Doxy that's required to treat chlamydia. And there are concerns too, but related to rectal infection, particularly in women who are, where these infections are not often detected. The next most common question that I think we've received related to EPT and concerns about, does CDC now recommend Doxy for EPT instead of azithromycin? In the MMWR, we recommended monotherapy with cefixime, consistent with the recommendation of monotherapy with ceftriaxone. And Doxy was mentioned for use for EPT in situations when chlamydial infection's not been ruled out in the index patient. Now, obviously, this change in recommended chlamydial therapy has made EPT more complicated, and there's several important aspects to consider. Keeping in mind, EPT has always been a harm reduction strategy and reserved for situations when we can't get the patient's partners to come into clinic for evaluation and treatment. We, in terms of pros and cons for Doxy, it is more efficacious for chlamydia. There would be less confusion for partners, in that they would get the same treatment as the partner who was in clinic. And we do have a long history of class use for acne for Doxycycline, and tetracycline before that. The cons, it's not been studied for EPT, and there are valid adherence concerns. There have been pregnancy concerns voiced, and then of course, we hear about side effects, particularly like the sun exposure and nausea if you take it on an empty stomach. For azithromycin, the pros are a single dose. It's studied in EPT, and it may enhance the efficacy of pharyngeal gonorrhea treatment when combined with Efficacy. There's some evidence for that. The cons is, it is less efficacious, particularly at the rectal site. There are pregnancy concerns that are being raised about macrolides now. And then azithromycin also has side effects. And a lot of the studies where they're compared head to head, the side effects are really not necessarily more common in the doxycycline arm. Related to the pregnancy issue, it is, there's a couple of articles I would draw your attention to. One was written by Cross in 2016, and reviewing Doxy in pregnancy, and that the safety profile for Doxy is significantly different than the safety profile for tetracycline. The point was made that the current Doxy doses are more than 10 times smaller than analogous tetracycline doses nearly 50 years ago. And that's at the time, around the time when these concerns started being raised about, changes to enamel and tooth color and those sorts of things. Also, the treatment duration is less than it was then as well. And it's, less than 14 days, except for, PID treatment. And it's safe in early pregnancy, perhaps throughout, and for children under 8 years. This particular author, when reviewing the literature, thought this. And actually, if you look back in our 2015 guidelines, we do specifically call out that it's contraindicated in the second and third trimesters of pregnancy. And this author concluded that restrictions should be softened. Now, a more recent article where this was reviewed yet again is that, the author there, Wormser, concluded that, Doxy does bind calcium less avidly than tetracycline, and that some experts, he acknowledged, feel it's safe to prescribe to pregnant women and young children, and he concluded more definitive data was needed. From the perspective of the treatment guidelines, CDC will continue to recommend azithromycin in pregnant women, but I think it's worth thinking about, and it's always hard to settle these issues when it has to do with treatment in the setting of pregnancy. But there are some evidence that maybe it's not as concerning as we think of reflexively. So I do want to leave some takeaways and remind all of you that azithromycin is an alternative for chlamydial treatment. Azithro and Doxy have both together been recommended as treatment for chlamydia since 1993, but azithromycin is an alternative that can be considered. Due to concerns about efficacy at the rectal site, additional post-treatment testing should be considered. And then, the wording in the more comprehensive document that we hope should be out hopefully sometime this month, we'll see, is that, there are adherence concerns that have to be taken into account. There are concerns about pregnancy. And then, there are pros and cons, as I highlighted, of specific anti-chlamydial agents for ET. I want to remind people that the STI treatment guidelines are not prescriptive. We can't cover every clinical scenario that can present. And that's why each clinician must make their best judgment based on the individual circumstances of the patient and utilizing shared decision-making. So with that, I wanted to remind you all of the resources that are available for the treatment guidelines. They will be updated, with the wall charts and the pocket guides and those sorts of things. We'll have limited numbers of copies of MMWR, hard copy. And then the app will be available in 2021. There may be a gap between the current app and the new updated app. We're still trying to sort out how to troubleshoot that issue, but just to make you aware, we may not have the updated app day one available. I want to remind you of the National Network of STD Clinical Prevention Training Centers and some of the resources through this network, of the websites here, as well as the clinical consultation website. And then, the clinical consultation is like a warm line that, you can get, you can ask questions and they will be triaged to the regional PTC's expert faculty for your area. And you can get responses in 1 to 3 business days, depending on, the urgency of the consult. And then finally, I wanted to remind you of the curriculum, the national curriculum that will also be updated, but will take a little while to get all these updates in that have CME, CNE, and I think some pharmacy credit with it now as well. Want to acknowledge all the people that have worked on these guidelines. I've got the guidelines co-authors listed here, and also Dr. Lisa Machevsky and Dr. Kate Milley, who are OBGYNs who've really dug into this doxy and pregnancy issue for us. And then, of course, all of you, many of you on this call have contributed significantly to these guidelines, and it truly takes a village to produce this. This document now is huge and has probably close to 1,500 references in it. So it's going to be, it takes a lot of effort, and we appreciate everything people have contributed to the process. So I will end it there, and I will stop sharing so we can do the chat, I guess, or questions.
Thank you so much, Dr. Bachmann. That was a phenomenal presentation. And we do have some questions in the chat, so I'll take them in the order that we received them. And the first one comes from Elizabeth Lebo asking, what are the implications for EPT treatment of GC-CT co-infection or CT infection for partners, given the possible potential teratogenicity, that's a word, teratogenicity if the partner is pregnant?
So, I mean, I think any sort of EPT materials that get sent out, just like we would have recommended before, should advise people, like if they're pregnant, that they really should be evaluated. I mean, I think we've had, in resources that have been historically given out for EPT, some educational information about, if the woman's having, if it's a female partner, she's having signs or symptoms of PID, that she really needs to go in and be seen. So I think those materials would need to be adapted to that. I think, but, like I said, there are concerns about pregnancy, but it's not, there's also, the reality is that this is a drug that has been used probably a lot inadvertently in early pregnancy. Not that that's what we want to happen, but I think that, just the educational piece, the resources you give the patients to give to their partners piece, can address some of this. And interesting, as you point out, it's there's that, they're almost like dueling organisms and orifices is the way that I put it, because there may be some advantage for GC at the throat to do the cefixime and azithromycin if you were to know that the partner had oral GC, but then also, if there's rectal chlamydia, there's that definite advantage for the Doxy. So it's, which is, we've put forth the recommendations, specifically in the gonorrhea part of the MMWR that we released. But if you actually look back at the CDC guidelines, we actually have not ever specified the chlamydia drug to use for EPT. And that's how the 2021 guidelines will be as well.
Thank you for answering that. And I just saw later in the chat that the question asker said you already answered it. So thank you for going back through it though. That was very thorough.
Sure.
We have more questions from Jennifer Isaac. Can you help clarify the rationale about pharyngeal gonorrhea test of cure 1 to 2 weeks after treatment? I thought this was too soon and could result in a false positive.
Mhm. So the rationale is that, we recognize that, we are going to monotherapy now. And, we've got to keep our eye on gonorrhea because we know that it becomes resistant to all the classes that we've thrown at it. We have concerns about the oral site as well in terms of potential for development of resistance, but also we know that the oral site is more difficult to clear for gonorrhea. And so that's the rationale for doing the test. In terms of the timing, you are correct that on the earlier side of that, more towards the 1 week, the potential for false positives would be higher than if you were to test them a little bit further out. But then the further out that you get from that, then you also start risking the reinfection scenario. So it's kind of a balance, and that's why there's a range. But yeah, the point's well taken, and this is something that we also are evaluating. We have another project in the field right now where we have several STD clinics that are going to be working to kind of evaluate this test to cure and implementation and other issues related to that.
Our next question is looking for some clarification. So Allison in the chat asked, just to make sure I'm understanding correctly, it says NC, we are treating GC with Rosafen 500 milligrams. If we suspect chlamydia as well, we add in Doxy 100 milligrams BID for 7 days. If a patient just has CT, we still use Zithromax 1 gram.
So, basically we're at a little bit of an awkward point right now because we've had an official publication of the GC MMWR. And that we did recommend that if chlamydia has not been ruled out, that you give doxycycline for 7 days. And then for chlamydia, we have proposed, and that's what it's technically until it's published, it's proposed changes to chlamydia treatment, that the treatment of choice for chlamydia will now be doxycycline, 100 milligrams BID for 7 days. That has not been officially released yet until the guidelines come out, but that was proposed in the public comment webinar. In terms of the pregnancy, we're not recommending that you use doxycycline when you know a person's pregnant, but I wanted to present that information about doxy and pregnancy to help allay some of the concerns around it. And also, I think we need to acknowledge that, there's also, while so far the data around azithromycin has been overall reassuring, that we're starting to see more about concerns about macrolides. Unfortunately, with pregnancy, it's always a little challenging with drug exposure in that setting. But yeah, hopefully that's clear that we're not recommending to use doxy in pregnant women, and we would recommend if you thought she was pregnant, she'd be tested. But at the same time, want to reassure people it's really primarily contraindicated in 2nd and 3rd trimesters.
So just a comment in here saying, I practice in a clinic for adolescents, so adherence is really dodgy, especially since they're often trying to keep care and treatment secret from parents. So I think that's definitely a consideration in all of this, right?
Right. And that's where, it's the art of medicine, right? I mean, the clinician does have to decide what is going on, what that patient's circumstances are, and weigh the guidelines, but also that person's circumstances in the decision-making process. This is not prescriptive recommendations.
I'm going to mispronounce this antibiotic in this next question, but I'll power through it. For the use of Efficacy and azithromycin to enhance EPT for pharyngeal gonorrhea, Can you share any studies that reference this? And thank you so much for a great presentation.
So there's a few. I'm not going to get the first authors on the studies. I'm drawing a blank, but there's not a huge amount of data behind this, but there are a couple of studies that demonstrate there may be some benefit for sulfixime treatment of oral GC to have the azithromycin with it, whereas we don't have that data for ceftriaxone and azithromycin. So, but it's not strong enough. The data, the amount of data that we do have is not strong enough to have driven a recommendation that you do always that you would use azithromycin with sulfixime for EPT. I don't know if that makes sense. It didn't reach that level of evidence, but I'm just making you aware that there are some studies that say there might be some advantage to using azithromycin with sulfixime for that purpose.
And I promise we're down to our last two questions, but you're doing a great job. So we have a question from Jessica Tillman asking, we have a couple questions about the STD treatment guidelines, clarifying the current recommendations. So should they contact the STD clinical consultation network or you personally?
For management challenges, if that's so for the clinical consultation, the National Network of Prevention Training Centers is really our training arm for DSTDP. So if you have, if you're having clinical management questions, then going through the STD CCN is a good way to go. If you have treatment, and they can also field questions about the guidelines as well. There will be a mailbox for STD treatment guidelines questions that will be specified when we issue the communication around the release of the guidelines. So you'll have that to ask specific questions as well.
And on the last question, they were just clarifying their state health department, so they develop standing orders for nurses.
Mm-hmm.
So a couple more questions. One did just pop up, and it was for the combination EPT with sulfixime and azithromycin. Would that be a 2-gram dose of azithromycin?
I think it was. I don't know that we've been that specific about the dose of azithromycin in our recommendation. So, I don't think that. I think there's some experts that would say it would be, but we didn't really go there. So it would, yeah.
And one more question is with the high, 90% of rectal infections missed in women, is CDC updating this on the 2021 STD treatment guidelines? Is that something you could share with us today?
I mean, I think that in the comprehensive document, I'm not sure they're going to have a 90% quote. And just to be clear, that is kind of on the upper end of those studies that have looked at women. So, but overall, the prevalence has tended to be over half. I think it was 68 to 90, 89%. But there will be, more detail about the rationale for some of these recommendations, and the fact that rectal infection in women is often underdetected and as common as, a point I think that will be made in the guideline text.
Super. I think that's all we have for questions. So thank you so much. Please joining me in a virtual round of applause for Dr. Bachmann, and thank you so much for sharing your expertise with us today. Following that great presentation, we have one of our best pieces of the program, which is lunch. So please take some time to eat, stretch your legs, walk around, and we will be joining back here on Zoom at 1 p.m. for a presentation about status neutral patient navigation with the goal of integrating PrEP and undetectable in a service model. So please join us for that at 1 p.m. and we'll see you then. Thanks so much.
All right, thank you.
Welcome back, folks. We're about to get things started for the afternoon sessions. And so for those of you who weren't with us this morning, I'm Michael Canty, the Senior Manager for Clinical Programs at NCSD. And I'm here to introduce our 1 o'clock speakers for today. Today we have Matthew Crean-Higgins from Evergreen Health in Buffalo, New York, and Ashley Zappelli from Trillium Health in Rochester, New York. Matthew Crean-Higgins is an Associate Vice President of Specialty Care at Evergreen Health with oversight of HIV treatment and prevention, sexual health, hepatitis C, and gender-affirming healthcare programming. Previously, he was Senior Director of the Pride Center of Western New York and worked for 12 years in the Erie County Medical Center's Immunodeficiency Service. In theater, he's written 7 original full-length plays and appeared as an actor in many others, including Naked Boys Singing and The Normal Heart. He was named to Buffalo Business First's 40 Under 40 in 2017, and as one of Buffalo Spree's Young Influencers in 2019. He can juggle while eating an apple, and he is my former supervisor, and we're very pleased to have you here today to share your work. And in addition, we have Ashley, who received her PharmD from the University at Buffalo School of Pharmacy and completed her PGY1 pharmacy practice residency at the Erie County Medical Center in Buffalo, New York. She is a credentialed pharmacist by the American Academy of HIV Medicine and is certified by the Board of Pharmacy Specialties in Ambulatory Care. She is also certified in New York State to provide patient care through collaborative drug therapy management and administer immunizations. In her current role as Senior Director of Sexual Health and Clinical Services, she oversees HIV testing, prevention, and rapid start treatment, as well as research initiatives at Trillium Health in Rochester, New York. She was also recognized by the Rochester Business Journal as a 2018 40 Under 40 honoree. Please join me in a virtual round of applause to welcome Matt and Ashley, who will be speaking about status neutral patient navigation.
Well, thank you, Michael. I think Dr. Zappelli and I are both definitely very excited to be here with you all today. This is a topic that is important to us. And of course, you're meeting us for the first time, but you probably heard within our bios that our paths crossed when we were younger too, and when we were both like sort of in training for the places that we are now. And so something that I usually like to say when speaking to audiences about this is like, it took a lot of us who got to the point that we're at a long time to get here. And it's hard having the conversations about making change. It's hard recognizing the paradigms that we worked with for a long time have changed. So please, like, I do want to say, like, as we get started, that like wherever you are in this journey, we hope that you are able to take something from this for your work. I have to get used to being the person controlling the slides, and my computer is already not letting me move forward. Okay, so we're going to start with a video that we made here at Evergreen Health about 2 years ago that gets us to like talk about in less than 2 minutes how we talk about HIV treatment and prevention as one conversation. And so again, this took us a long time to get there, but we want to give you a sense of like how we talk about these things. So I think I've done everything right to share the audio too, but I'm going to rely on Michael and Ashley to like indicate to me if when I mute my line, if you're able to hear the video when Kelly starts talking.
A lot has changed for the better when it comes to HIV treatment and prevention.
We now know that positive people who reach an undetectable status cannot transmit HIV.
And for those who are negative, there is a pill called PrEP that is 99% effective at eliminating the HIV risk.
And still, there are people who are scared to get tested and know their status.
But at Evergreen Health, you don't have to be scared.
We work with people of any HIV status to get them on PrEP or to get them undetectable quickly with one goal, and that's to get them to confidently say, you cannot get HIV from me.
You can't get HIV from me.
You can't get HIV from me.
You cannot get HIV from me.
You cannot get HIV from me.
And so that's sort of a segue into what our goal is today. And our goal is to teach you not just about like the clinical practices that our organizations have put in place, which of course Dr. Zappelli is more qualified to talk about than I am as a pharmacist. Certainly to recognize those things, but also to recognize our opportunity to change the conversation about sexual health away from stigma and toward one that celebrates connection and choice. So in addition to the fact that the way that HIV treatment and prevention has changed from a scientific standpoint, there is also the reality that with the information we have, we can change the way that we talk about sexual health and get away from fear-based messaging and more toward one that celebrates what sex is all about, which is not just what people think it's about, but also about recreation and entertainment and connection, procreation, all of the many, many things that are too long to list right now that people may engage with sex for.
So I'm going to just get us started now a little bit with how do we get our patients talking to us about HIV? As Matt mentioned, we're all in different places, and I've noticed a lot, even more so lately, I think, post-pandemic, wherever that is folks are really coming in and asking for STI screening, but really not seeing the risk for HIV right now. So I encourage you all, to just see where you're at and taking one step forward to take this opportunity when a patient is here and maybe they haven't been screened for a very long time to just provide some education to lay that groundwork, to have a conversation around HIV, status neutral, and a comprehensive prevention plan. So as most of us are really familiar with, the behaviors that increase risk for STIs also increase risk for HIV, such as condomless sex. And sometimes numbers really can speak to folks in a different way. And I encourage you all to, if you want to bring in data or metrics to a patient conversation, just trying to do that in a more educational way versus using it as a fear tactic. If you have someone who you're in there treating for rectal GC, and we know that 1 in 15 men may become HIV positive in the next year, talking about what you can do with the patient for an informed decision-making and prevention plan in the future to keep them HIV negative. I think another thing that just really isn't on folks' radar is how risk may change, especially HIV risk, with who they're having sex with. the genders of their partners, what body parts they're using for sex, and where they're having sex specifically. You know, like if, as we know, there's a stat, like if you live in DC, 1 in 17 people will become HIV positive in their lifetime. So just using that as an educational tool, especially if your clients or your patients are traveling and meeting people and having sex in different locations from where you may already be. Next slide. So I like to engage the patients to allow them to tell their story, to really drop the stigma, drop the assumptions, and to let them speak to you about what their sex life looks like and their decisions, and really empower them in the conversation. So these are just a few things that we use in our conversations, and you may use something differently or something similar to this, but just allowing them to tell you, what does condom use look like for them when they're having sex, what are the gender of their sexual partners, and what body parts do they use for sex. I think that's really an important question, because it shows them that you're actually taking time to learn what you call your body parts, and then with that information can provide the best recommendations clinically to keep them HIV negative or to prevent transmission to others. Other things is, you know, how do you discuss HIV status with your partners? And then what Matt and I are really here to talk about is the comprehensive plan going forward. So, you know, if there's just one thing that you can do to change what you're doing now in your encounters with clients around STI assessments or HIV risk, you know, ask them, do they know that there's a pill out there that can prevent HIV? And if you can even take it to a level further, which Matt will get into a little bit later, is around U equals U, or undetectable equals untransmissible. And what does that mean if you're having sex with someone who's living with HIV, but their HIV viral load is undetectable? And really using that as a conversation to inform them about what their risk truly is. Next slide. So many of you may be familiar with cascades and kind of showing where the gaps in care are. And I'm really familiar with this in the HIV world, but there's some data coming out to show cascades around PrEP. And, you know, I already said, don't miss the opportunity. You have patients in front of you coming in, talking to you about sex, getting STI screening. You do all this work, you engage them, you talk to them about what PrEP is, and then they're like ready to start. Where do you go from there? So everyone's program is going to look a little bit different. And one option is to do same-day services within your own facility. So same-day services, you know, you may engage someone in HIV testing, STI screening. They may be interested in PrEP. They're a PrEP candidate because their HIV test is negative, and you can prescribe that PrEP that day. It may look a little bit different for you. You may link them to an outside provider. You may engage with another provider via telemedicine. There's just a lot of options, and I welcome everyone to really think outside of the box. What we saw in one of the studies that looked at same-day PrEP and STD clinics is it was really highly acceptable by patients, feasible, and safe. So you see just in the first column, 131 patients met with a patient navigator, you may call them a PrEP specialist or a tester, whatever that is, talk to them about PrEP, and over 2/3 of them initiated PrEP same day, which is a really high percentage and higher than I typically see, but you can see that there is a little bit of a drop off when folks follow up for their 1 month or 3 month appointment, but there is really high utilization or acceptance by patients. I think it's really important too, because PrEP patients tend to be high risk for no-shows or loss to follow-up, and this may be compounded by, you know, social determinants of healthcare, such as low income and less education. So if someone's with you right now, you have that opportunity to start a prevention plan versus scheduling in a week or in 5 days where you might lose them to follow-up. I think also right now, being the opening up of several things post-pandemic, we have a lot of folks who discontinued PrEP over the year. So we're doing a lot of re-engagements, and to try to be as welcoming to those patients as possible and meet them where they're at when they're ready to start, because others on this call may have experienced this too. We're doing a lot of new HIV diagnoses or rapid starts, which we'll talk about a little bit later. And many of these patients, I would say in my experience, over 50% have previously been on PrEP or have scheduled a future appointment to restart or start PrEP. And so that feels like, you know, a real missed opportunity for myself. And how can we change our program to meet patients where they are more quickly? Next slide.
So what we're showing right now is the status neutral service delivery model that was first introduced to many of us by the New York City Department of Health under then the direction of Dr. Dimitri Daskalakis. And so what it demonstrates, and which we'll talk about a little bit more as we get into like how we've designed our own programs, is no matter what HIV status a person comes into, there is a path for them that they can start right away or almost right away, depending on what you have set up for them. And the paths are pretty similar. As a person who's worked in like the non-clinical side of this work for a long time, without ever glossing over the importance of the clinical part of it, what people would talk to me about when I was in direct service and even now in my current role is that the social stigma around an HIV diagnosis is the biggest thing that prevents people from taking action around testing. And so when we look at the status neutral service delivery model, we can see that whether a person is HIV positive or HIV negative, we can engage them in treatment or prevention services that will allow them, as the video showed at the beginning, to ultimately be able to say, you cannot get HIV from me. And certainly the medical eventualities of an HIV diagnosis, the medical necessity that a person might feel around enhancing their prevention services are certainly important. But for many patients, the ability to say that is a big motivator. And we have not yet been able to flatten the social dynamic where the general community sees HIV treatment and prevention as equals. There is still certainly a social stigma around an HIV diagnosis that we are not pretending doesn't exist, but we are acknowledging that we have an opportunity to get those closer to equal, because though the paths there are different, you can achieve that goal of saying you can't get HIV from me, whether you are HIV negative or positive. But as you look down that, and we'll show another slide later on, the steps are almost exactly the same to get there. So being in HIV prevention services, being in HIV treatment services, the path is pretty much the same. It's really the medication that is different, and of course the way that it works. So we really, when PrEP was first new, we used to have to almost like kind of prove that a person needed it. So like if any of you have been working in this since PrEP was first introduced, like you might even remember calculators that we had to use like to justify really to insurance companies that a person was an appropriate candidate for PrEP. And like you would, I mean, let's not like double down on it too far, but like it would have to be like, hey, tell us a little bit more so we could get a person a higher score up on the calculator. But really now, I can't speak for, I know this is a national audience. In New York State, it's not possible anymore for insurance companies to deny a person access to PrEP. And so something that we very, very often say is that PrEP is really a good option for anyone who's currently HIV negative and wants it. So anyone who is currently HIV negative and has interest in it has some level of perceived risk that is not really for us to say yes or no to, because the person may have what they're willing to tell us, and then they may have some other things that are going on in their lives that they're not willing to tell us. And it shouldn't be a matter of getting them up higher on a calculator to justify that and having to say like, tell us a little bit more so we can score you higher. But PrEP is certainly, we are aware that even though it's good for anyone who's HIV negative with any amount of concern for ongoing potential for exposure, it is especially right for anyone who has multiple and or anonymous sexual partners, anyone who's not a condom user or does not use, not a regular condom user or does not use condoms at all, any person who's assigned male at birth and has male partners. So when we say assigned male at birth, that also is inclusive of people of trans experience whose initial assignation at birth is male. Anyone who uses injection drugs or mood-altering drugs such as alcohol, methamphetamine, cocaine, or ecstasy. Sometimes people will ask us questions about like, well, why are drugs that are not used with syringes being included in this when needle use is what is most commonly associated with HIV risk and drug use? And we are acknowledging without judgment that mood-altering drugs do sometimes cause a person to, their mood is different. So they may do things a little bit differently when they're under the influence of one of these drugs versus when they're not. And so we acknowledge that within that is also what risk reduction measures a person may take when they are under the influence of a substance. And so PrEP is a good option that a person can routinize, and then they've made that decision and they're able to do that, whether they are on, whether they are using drugs at the time or not. A big thing that is frequently said to us by people that don't have a lot of experience working with the drug using population is like, can drug users be adherent? And like something that I say very often is like drug users are very good at taking medication. It's like almost the same thing. And so when people say like, I don't know if drug users can be adherent, it's really not a culturally aware statement to make. And we have not seen really significant or any difference in the adherence abilities of people who use drugs versus people who do not disclose that they use drugs. Anyone who has survival sex in exchange for money, housing, etc. PrEP is a decision, as well as HIV treatment, that a person can make outside of the transaction that may be involved in sex work. And anyone who has a partner who's living with HIV, or a partner whose HIV status is unknown. We do want to acknowledge that if the HIV positive partner is undetectable and on ongoing treatment and they're in a mutually monogamous relationship, PrEP may not be necessary in that situation, but it is something to consider, especially when an HIV status is unknown or if the person is not consistently undetectable. Anything you want to add to that, Ashley, at all before we next slide it?
No, I was really reminiscing though on that calculator, and I remember, so it's July. I remember PrEP being FDA approved in July of 2012. So we're at 9 years, and I remember actually rolling out the program, and there were documents that you had to have the patient sign to like attest to how PrEP was recommended. So of course we encouraged condom and regular testing, and it was like a coverage for liability for us. And it was just, it wasn't evidence-based by any means. And of course we've moved far away from that. And like you said, if someone is coming forward and asking for PrEP, I think that our New York State Department of Health guidelines recommends as well, is giving them the opportunity to make that decision and develop trust with the provider. And you most likely will learn more about what's going on in that individual's life over the next 3 to 6 months. So this is a workflow that's published by the CDC for an idea of what a PrEP clinic or workflow might look like. And like I said, you know, we're talking about options for patients, but there's really options for you as a service provider too. And this may look a little bit differently for you as well. So I'm very used to combining steps 1 and 2 of screening and PrEP initiation, but others may not be, and it may even have some extra steps. But I think that the significant amount of work does happen in that first screening appointment, which you all are probably very familiar with, doing testing encounters and getting a risk assessment. Then the next step is linkage to care. And so I think there's a lot of opportunity of what that could look like. And I know many, you know, sexual health or STD clinics don't have a ton of resources, but just really leveraging what's around you, what other providers are around you. If you're seeing the priority populations within your clinic, how can you get the patient what they really need? And whether that's a linkage to another provider nearby, physically in person, or could it be through telemedicine? We partner with an STD clinic that's over 2 hours away from our clinic because they just don't have the resource to actually initiate PrEP. We also partner with some STD clinics who are willing to initiate, but really just don't have the bandwidth for maintenance and ongoing appointments. So I think that if you're doing HIV testing and you know that the person their screening test is HIV negative, you do have the ability to initiate PrEP in that moment. But we'll go a little bit more into detail around the HIV test and how some situations you may not feel comfortable for that. And then as for follow-up, I really think too is historically it was always you had to see your patients every 3 months. And I think especially over this last year, we've learned a lot, but I think PrEP is at a point where it really needs to be individualized. I have some patients that have been on PrEP since it was approved in 2012, and they're very stable. There's really no need to come into the clinic every 3 months. So the things that are listed under this follow-up, a lot of these things are just done over the phone. We do need HIV testing every 3 months. And as a prescriber, I really encourage you never to prescribe more than 90 days of PrEP because you want to encourage that HIV test. And perhaps if for some reason someone is not adherent and potentially a seroconverting, you want to catch that as quickly as possible. But a lot of these follow-up questions, such as, you know, adherence assessment, any side effects, that can really be done over the phone, and that could really allow some more access for the providers. Next slide. So as far as HIV testing, this also came from the CDC. So the top gray box is looking at antibody tests for HIV, which can be done rapid test, oral swab, or can be done through a blood draw. So remember, with that type of test, you're really looking at a 90-day window period. So really have to consider that with your patient. So pretty much every PrEP visit that I initiate, I ask, when was the last time you've had condomless sex? generally, if I'm starting someone on PrEP or other risk factors, but generally it's definitely within the last 90 days, if not within the last month. So I always am screening for post-exposure prophylaxis prior to starting PrEP, but it also gives you a little bit more information as to what other HIV screening modalities you want to incorporate before starting PrEP. So if the third generation antibody test is negative, but they've had signs or symptoms of acute HIV, or they have potentially had high-risk exposures but no symptoms, I would encourage you to do some further screening. And so here they have preferred options such as doing the antibody antigen test, which we know is the fourth generation test that is available, rapid test through the Alere Determine, or also sending for the viral load assay. So even the antibody antigen test does have a 4-week window period. So often there's folks that have had condomless sex in the last month and you want to start them on PrEP, but you want to really be sure that they don't have acute HIV. So I almost always at a PrEP intake order a viral load as well. Viral loads are generally positive within 1 to 2 weeks. And since we are recommending, the CDC is recommending screening more frequently, you know, at least every 3 months, we are really catching acute HIV infection, where it does say if the viral load is less than 10,000, you want to repeat because you're not sure it's a lab error. I really have never seen a lab error with the viral load, but have started to detect HIV with low-level viremia around 400 copies. And when I repeat it, you know, we're starting to see very high viral loads. And that's really the time where someone is most likely to transmit the virus. So just being, I think, a little bit more aggressive with your HIV testing to detect acute HIV is really important to get people undetectable, to not allow them to pass the virus on to partners, and just to provide more information, getting them started on HIV treatment as quickly as possible. So if the third generation or the fourth generation test is HIV negative, you can assume that they are HIV negative. And then just in summary, I'd like to get a viral load just to close that window period, even of the 4 weeks on the fourth generation test to be sure. And that would be a blood draw. Next slide.
So when we talk about initiating treatment ASAP, that's something that both of our organizations are early adopters on. Trillium got to it a little bit before we did. And that's like the notion that when a person has an HIV rapid test even, which is not a confirmed diagnosis, that there is a lot of reason to start them on treatment right away. When Ashley was talking about the difference, the viral loads and such with the different antibody and antigen tests, the first rapid start that we actually did, which was in September of 2017, the person did have a recent exposure and they did have a negative fourth generation test, but we also got from another facility a viral load, which was in excess of 1 million. So it was like it was kind of a sobering moment for us to realize, you know, you have to sometimes, the clinicians have to sometimes look at several things to get the full sense of what's going on, especially in a situation that's changing pretty quickly. A lesson that we learned in that situation, I mentioned that was a situation that happened in September. By November, that person was undetectable. And it was a moment our providers were not totally ready yet for rapid start. They were just about to get there. And then we had a circumstance that pushed everybody, all of us who were involved in the situation, a little bit forward. And it became a moment that we couldn't go back from in terms of like understanding that it was what the patient wanted, the patient understood it. It was really at the direction of the patient feeling like they needed to do something in that moment to address what was happening, but then also seeing the impact of it showed us that it was the right thing to do. And once we knew that, we couldn't kind of go back from it. So we designed many things, including the programs that I oversee, to account. Well, I don't want to say to accommodate that because that sounds almost like it was like an inconvenience, but to account for the fact that when a patient was ready for that, which is almost always, that it is the right thing to do, and that when we have the ability and a process to do it, there's not really a reason not to. So immediate linkage to care actually increases retention and care. When we looked at our first year of people that we rapid started, we actually noticed that they were more likely to stay in care. When I think back to when we were earlier in our careers, like people could be HIV positive for several years before they were actually engaged in taking medication for their HIV infection. And that's what the protocols were at the time, but there was a lot that could happen along the way. But we were noticing that the people that we engaged with Rapid Start were more likely to stay in care than people that we engaged during past paradigms and modalities. It also is an opportunity to decrease morbidity and mortality. And so when I think about Rapid Start, and again, I am not a doctor, not a pharmacist, not a nothing, but I've been in the field for a long time. And so a story I often tell, when I worked in a hospital setting in 2009, and I was a social worker in the clinic there, we had two people that were diagnosed on the same day. One was admitted to the hospital, and they had essentially a CD4 count of almost nothing. And then we had a person who was inpatient, or who was in our walk-in clinic, who was also a Suboxone patient. He was a person who used drugs. He was also an MSM identified person. We had tested him HIV negative just a month before that, and then we had a preliminary positive on him. And now this is a story from 2009. And so one of the doctors I worked with at the time, Dr. Neil Zipkowski, who is a renegade, started both people on the same medication the same day. The person who was inpatient with almost no CD4s, and the person who was in our outpatient clinic who had a negative HIV test the month before. And I remember like it was yesterday, everyone else who was working in the clinic saying like, he's lost his mind, like he's got this person on medication, what are we doing? We don't even know if the person is HIV negative or HIV positive and he's on medication already. And what Dr. Zipkowski told us at the time was like, folks, this person is HIV positive. Like, he has disclosed to us that he has shared syringes since the time he was here. He has had condomless sex. He has an HIV test that is preliminary positive. He deserves treatment. This is what I'm doing. And basically told the rest of us to get away from him, which we were like mad about, but like it was none of our business. He was the doctor. And by the time I left that job, which was about 3 years later, we watched both of those people, you know, watched their labs over time. And the reality of it was they both ended up doing well. The person with almost no CD4, like his CD4 never got super high, but he got much, much healthier, cleared the opportunistic infections that he had. But the person that we all, which was none of our business, were telling Dr. Zipkowski not to start on medication, never had a CD4 count that went below 1,000. And so it was like a moment that we all sort of remembered, but then at the same time, when Rapid Start started being recommended, like 8 years later, it still seemed shocking to a lot of us that were in the field, even many of us who had seen it be effective when essentially a renegade doctor did it without it being the standard practice at the time. Viral suppression, of course, decreases transmission, and that is something that our understanding of has increased tremendously over time. At one time, people would talk about reducing the community viral load. You don't hear that said so frequently. We focus much more often now on a person's individual health, but the more people who are currently HIV positive that we can get to HIV undetectable, the less onward transmission there is going to be going forward. And so that's another reason to do that, is to recognize that the more that we treat HIV in individuals, the less opportunity there will be for HIV to move from one person to another. Other considerations, which I probably should let Dr. Zappelli talk about more than me, are pregnancy, age over 50, acute infection, and advanced disease. Anything you'd want to add about those, Ashley?
Yeah, so for people who are pregnant, we definitely try to get them on medications as soon as possible so we don't transmit HIV to the baby. HIV and aging, HIV is an inflammatory disease. So as we age, a lot of inflammatory processes are increased, and HIV would be another addition to that. And actually, antiretroviral therapy can reduce inflammation. Acute infection is when you were recently diagnosed in the last 6 weeks where your viral load is very high, similar to what Matt just described with greater than 1 million viral load. And it's very easy to transmit virus. Once again, antiretroviral therapy can reduce that and to reduce the risk for transmission. And advanced disease. So once again, AIDS defined, more likely to get opportunistic infections. Our treatment can increase your CD4 count and help really protect against any OIs. And, you know, Matt, as you mentioned, like, I think the benefits of Rapid Start and starting early, like, we're still learning those things. So I think, like, one thing is inflammation, starting people on treatment, reducing their viral load, and also the HIV cure is still very much in development, as we know, when we're very hopeful that someday we will get there. But who's going to be the right candidate for cure? Who knows really yet? But if you start treatment really early, and you can interrupt that process of really where the virus embeds into these viral reservoirs in our body, which our treatments cannot go in and wipe out right now. If you start as early as possible, you know, what is the benefit for that patient? I can only assume that it's going to be great. And maybe in the future, they're more of a candidate for cure than some others where we really don't know yet. So those are just some things that I know is in chatter and in investigation and research right now. Next slide. So, you know, the data shows that starting people on HIV treatment gets you undetectable much quicker, right? So back in the day, we used to actually wait till people were sicker and their CD4 count was low, like less than 200 or AIDS defined, and then we got to 350, then we got to 500, and then finally, universal antiretroviral therapy was recommended for everybody living with HIV. Now, the difference between universal and rapid is that although everybody living with HIV is offered treatment, it is not started on the first day of diagnosis. Usually you get some blood work, you get a resistance test, you bring the patient back, you discuss it. Sometimes you give them an M&M pill pack to go home and see if they can take a pill every day. And so usually you're starting treatment on someone in 3 months, maybe if you're lucky, 1 month. But it just takes a little bit more time to get them started on treatment, which of course is delaying the time to viral load suppression. And that's the time when you can actually prevent transmission. Rapid Start, we're starting treatment on people before we actually have their confirmed diagnosis, as Matt mentioned. But you're seeing them getting virally suppressed incredibly quick. And I can give you some real world data on that in the next slide. So we've been doing Rapid Start since January 2017. I vividly remember this moment of loading a pill box with probably 20 HIV medications and giving this person like the kitchen sink to go home with. And really now Rapid Start is 1 pill once a day. You know, that's just one other add to our discussion of whether we're going PrEP or we're going Rapid Start. It's really looking very similar. So at my clinic, I work in Western New York, and the county I work in has about 60 to 80 new diagnoses a month. So it's not super high. And we do a lot of the Rapid Starts in our county. But we have been doing HIV treatment for many, many years as a Ryan White C clinic. So we were able to compare our Rapid Start data to our standard of care. So standard ART is where we provided HIV treatment to folks, but we didn't necessarily start them on the very first day. Where Rapid Start, we start them on their first day. So you can actually see that the time from diagnosis to viral load suppression, which you can define as viral load less than 200, you're looking at their previous standard of care took about like 3 months, where Rapid Start, it's about a month. And if you even go to a viral load less than 50 with standard ART, it took about 6 months. And with Rapid, we're looking at not even a month and a half, which is really important from the prevention standpoint. Yes, and definitely the person and reducing morbidity as well, but as far as preventing transmission to others. Started without resistance testing. With Rapid Start, you don't get a resistance test before starting. You start a very durable medication that is evidence-based, that shows it is shown to overcome many baseline resistance, and the DHHS guidelines recommends a few different regimens that are best for that situation. So you actually start treatment without that information, but you do still order the testing at baseline and you get it back in like a week or two. What's important to know is that even though I started at this time period 51 people, and it's been many more since, on treatment without this information, nobody's had to change their medication regimen because of baseline resistance. And the medications we use right now for HIV treatment, they're just so potent and durable. They are often able to overcome any baseline mutations that a person may have acquired during seroconversion. Next slide.
So this is something that we just like go over very, very quickly to just demonstrate that there's rationale in either direction, whether it's whether we're starting for people for their benefit or for the individual, or for the public health benefit or individual health benefit. There's reason to do it in both directions to get to that same goal. And this is something that we used, our two organizations did several conferences during the before times. We were like on a national tour. Michael, when he was talking about my bio, like I wanted to be in musical theater when I was a kid. I thought I was going to go in Joseph's Amazing Technicolor Dreamcoat, but instead it was about rapid treatment and PrEP was my national tour. So one of the things that people would ask over and over is like, how are you condensing all of these things? And so we developed with our colleagues at the New York State AIDS Institute, just an example of like, it used to be that all of this stuff happened over like a minimum of 5 visits. And so we've essentially crammed those 5 visits that used to happen either in 6 months or over the course of several years into one single day. And as Ashley mentioned before, we haven't seen people needing to change medication. We haven't seen any type of difficulty that people have had. As I had mentioned earlier, we actually see a higher rate of retention in service, but also something, and we'll talk about this a little bit later on as well, it makes a lot of sense to people. And so when we were on that national tour and people would tell us like, you're doing this too fast or you're cramming too much in, patients can't handle this, something that we would explain to people is that patients, our clients, community members do not have the same baggage that we have as service providers about the way that things have always been done. And so in the past, when we would tell people like, you're HIV positive, we're gonna like, you know, get to know each other and monitor your labs. And at some point you're gonna get to 500, 350 CD4, and then we'll start talking about medication. People, you know, they accepted that because the service providers were telling them that that was the way. But like people who are just being diagnosed HIV positive today, they don't have that baggage. They don't have that history. They don't know that that's the way that things used to be done. And when people say, you have this likely HIV diagnosis, we can do something about it starting right now, it actually makes sense to a lot of people, and they don't tend to need these 5, 6, 7, 20 visits to get them ready for that. And so it's really kind of like a lot of times in developing this type of programming, it's about letting go of the way that things have always been in favor of what is actually possible now, much of which we acknowledge wouldn't have seemed possible even 5 years ago.
Yeah, so I think too that with Rapid Start and what we're seeing today is patients are just more informed. And if you, from where we started in this conversation today, if you bring in the discussion around U equals U into every testing encounter, it's not so scary. And that first test that is a positive and a diagnosis and leads to rapid test, it's a Rapid Start. It's not always a crisis, which I think we as service providers who have been in this for many, many years, that's what we envision this first day to be, is this total crisis. And definitely it is a life-changing diagnosis, and there are situations like this, and you should plan for support systems around that human being that day and going forward. But for the most part, I'm hearing people more aware of U equals U and how you can live a really healthy, normal life being undetectable on HIV treatment. And that adds to the willingness to start treatment that day. I would say that an area that definitely needs some more publication or literature is around patient satisfaction. So, you know, Matt just mentioned, you know, it's kind of more that the providers or us are worried about it and are concerned about doing Rapid Start, where the patients are anecdotally showing to be pretty satisfied with it. So I've been looking at patient satisfaction for Rapid Start, and after being on treatment for 1 year, reflecting with the patient on their experience and asking them, how did you feel about starting medication immediately after your preliminary HIV results? You know, and in summary, it's very similar to what Matt says. Like, they felt good about it because they were doing something for themselves, often in a time of a lot of unknown, because it could just be after a preliminary positive test. They don't even have a confirmed diagnosis. So they're sitting there waiting, you know, a couple of days for the blood work to come back, but at least they felt like they were doing something. So just a couple like things that stood out is, you know, the patient felt good, very glad that I did it. I did not want to waste any time. I just wanted to get everything over with. I was optimistic. I was ready to get started and was happy to start something. So really, once again, individualizing the treatment plan for the patient, which it seems from our experiences that most everybody is willing to start the same day. Next slide.
And this slide is actually one that Michael developed when he was still working here at Evergreen to demonstrate, as we had said before, in the New York City status neutral navigation like map, the steps they're almost the same. Like, there's some things that are opposite in terms of like, to start PrEP, we must confirm you're negative. to start HIV treatment, we must have some sense that a person is HIV positive. But essentially, the steps are the same, and they get you to that place of no onward transmission. As Ashley mentioned earlier, there are people who are coming back to PrEP who went off for reasons that were their own due to the ongoing situation, which is what I call the COVID-19 pandemic, just because I got tired of saying those words, so I moved to ongoing situation, which I'm also now tired of. But I respect it, even while being tired of it. And some of them are coming back HIV positive. We have certainly had, in the time that we have been offering PrEP, we have had people who've come in believing today is the day that they're starting PrEP for whatever reason. They're like, they weren't on it before and they're on it now. And it's not uncommon. You know, the world has changed a lot. And so something that I say sometimes is like, when I'm a little personal disclosure, I'm 41, I've been gay my whole life. When I was in my 20s, like amongst most people I interacted with, the conversation, if there was any conversation, it was around basically there was an assumed condom use amongst like my generation and people I interacted with. These days things are very, very, very different, and there's less condom use, and the discussion, if anything, is more around when people are going to use condoms, and that's a fact, whether people want to acknowledge or admit it. It's just something that has changed dramatically over the last, I would say, 8 to 10 years. Maybe a little bit less time than that, but like it's just a reality that is different than it was before. And so within that, there is a sense that some people who believe themselves to be currently HIV negative begin doing things that they you know, may think like, I should be on PrEP before I do this, but trying it a few times before then. And we've had people come in believing they were going to start PrEP that day, and we find out during the course of that visit that they are actually HIV positive. And as Ashley said, in the past, we'd have thought of that in like a crisis mode type of thing, but we are working very hard now to say, this is in some ways an opportunity. The person, when they came through the door that day, they were already HIV positive, and someone needed to tell them that, and now they have an opportunity to take action. So I'm not saying it's 100% perfect. I'm not saying that we don't sometimes still feel crisis about that, and I am certainly not saying that it may not feel like crisis for the patient themselves. But we have an opportunity that we didn't used to have to say like, okay, you came in for this. What we actually found out is that something else is going on, but we're not just going to wait the way that we would have in the past. We have the option to do something for you today. With PrEP, when we talk about PrEP with daily use, we talk about reaching full protection in 21 days. We talk about 45 days to reach undetectable. The stats that Ashley just showed show that it's actually a little bit sooner than that, but ultimately, you know, after about 6 weeks or so, from a social standpoint, both the PrEP patient and the HIV treatment patient are able to pretty definitively say, I pose no risk of onward transmission, which is what motivates a lot of people on a community-based level.
So this is just a couple examples of from my clinic and Matt's clinic of just some creative that we pushed out to the community to engage them, to provide marketing materials that is reflective of who they are and relevant, and just to show that talking about HIV and HIV prevention can be really empowering. And really moved away from the historic fear tactics, but really, really empowering and even a little bit fun. So this is 5 years old, but we did this emoji campaign, and it was really well received by younger people. And as you can see, most of my images here is around younger people, as that's really the demographic we're seeing, mostly newly infected with HIV right now. So just being attentive to the communities you're serving and making sure some of the materials that may be engaging to them are relevant. Next slide.
Some examples of marketing materials that we've had, these are specifically from the last year or so. And something that we heard from our patient population was a sense that the HIV movement in general had gotten a little bit away from talking to HIV positive people. And there was a feeling amongst many of our HIV positive patients that we were talking about PrEP a lot because it was new, but we were no longer as directly talking about their experiences. And also there was a sense that we as a large service provider had a responsibility to make sure that the message about undetectable was getting out into our communities. And so we made sure that whenever we are advertising or having marketing messages around sexual health and PrEP, that we are also including messages that speak directly to our HIV positive population, but also tell information to the larger community about the reality of what is possible with treatment now. So when you see the one that says achieve undetectable, we like to think about that as something a person achieves. It's an accomplishment for them. And it's not one to be taken lightly at all. But we say if you're HIV positive, treatment can reduce your viral load, preventing the spread of HIV to others. That's a message to the patients, but it's also a message to the larger community as well to rethink how they think about HIV diagnoses. Something else I like to brag about, none of these are stock images. We got away from the use of stock images as an organization for a few reasons. One is that it's really hard to find good quality images of anyone who's not what I would consider like a statistical majority. So anytime that we looked for any type of photo for anyone who was non-white, the selection was, there just wasn't a lot out there that we felt was really, really good and high quality. But also something, whenever we would look for images of persons of color, images of people of LGBTQ experience, you could frequently tell that they were not from Western New York. And so we're based in Buffalo, which, I mean, it's the second largest city in New York State, but it's a lot smaller than New York City. So we'd see these stock images and it'd be like two gay guys, they'd have a wedding ring on. We'd be saying they were on PrEP for, reasons that are their own. Relationships are what they are. But they'd be like standing next to a humongous skyscraper. And we would hear from our patients and our potential patients, like, that's just not a Buffalo story. Like, that's an ad for New York City, like for a Buffalo service. So we moved to people who actually live and work in our communities, many of whom receive services with us in locations that are, I mean, all of these are like kind of in portrait mode, so you can't see the backgrounds, but if you were from here, you might even be able to recognize like where the person actually is. And that is all of our formalized presentation. So I believe now we move on to our moderators for questions and answers. Unless, Ashley, you had anything else you wanted to add to that?
No, that's great.
Thank you both so much, Matt and Ashley. And we do have some questions. So we'll get started in the order they came. Our first one is, have you ever started a patient on ART who in the end was not confirmed positive, so false positive or false reactive? And if so, could you tell us a little bit about that?
Sure, I'll start. We've done that actually many times. I think the 4th gen rapid tests can be sensitive to other things other than HIV. So we still do talk about risks with patients, and if it makes sense, if there's a risk, then we will move forward with rapid start. And so the confirmatory blood work is generally back within 24 to 48 hours. So we bring our patients back in and review the confirmatory blood work, which may then indicate that they are indeed HIV negative, but is a great opportunity then to really engage them in prevention. Usually the rapid start medication that you have started on actually has PrEP in it, just with another medication. So they have had the opportunity to kind of like test it out, notice how that they're going to react to it for as far as side effects for a couple of days, and just really engage them in prevention going forward. There's not really a risk in doing that. The drugs today are really safe and well tolerated. We use a full HIV regimen if we were providing post-exposure prophylaxis as well. And in most cases, people remain HIV negative in that. But I think there's an incredible benefit of starting early with the thought that the person will have a confirmed diagnosis.
Thank
Our
you.
experience would be the same. Our only times we did it, they were related to false positives with the 4th generation test, as Ashley mentioned. And none of the situations was the person upset about it though. Like, it's very few of them, but like when they talked to the nurse who told them like, you're not actually HIV positive, the reaction was sort of like, well, that's really good news, but we did a lot with the information that we had at the time, and people, we have not yet heard, it's a small number of people, we've not yet heard yet, like, oh, I wish I never did any of that. There seemed to be like an ongoing feeling of, we took action on what we knew in the moment.
I know these are case studies, but off the top of your head, did any of those patients transition to PrEP?
Yes, yeah. That very often is the case, is they do transition to PrEP. Like I said, they took a pill every day. They even took the actual medications for PrEP, so they feel even better about going onto it because they know how their body reacts to it. They also kind of have a sense of the support systems like the organization may have to help support them with medication adherence or getting the medication. So like Matt said, although we started them on full HIV treatment, assuming that it would be HIV positive. You know, we did everything we could with the information we had at that time. And I think it provides the patient a little bit more trust with the organization.
Our next question is, how do you handle on-demand PrEP or 211? So this is, if you're unfamiliar, the dosing regimen where patients take 2 doses of PrEP leading up to a sexual encounter within, I think, 24 hours, and then take 1 pill for the following 2 days. So this question is, how do you handle on-demand PrEP, and where does it fit into your program?
So for us, the FDA has approved 2 medications for pre-exposure prophylaxis or PrEP at a once daily dosing regimen. So that is my preferred, as we know that is what is FDA approved. However, we're here for options, we're here for harm reduction and what works for the patient. So if a 1 pill once a day doesn't work for the patient for whatever that is, this is an option to have. I also think it's a great tool. And by the way, this data is only in men who have sex with men or transgender women for 211. So you have to make sure that it is protective in your patient. But I think it's also a great tool for folks who are discontinuing PrEP and actually have that conversation with you. You can give them a prescription for 211 just to have on hand, because generally when people are ready to re-engage in PrEP, it's after behaviors or vulnerabilities that have already occurred that put them at risk for HIV. And unfortunately, sometimes it's just too late and that re-engagement HIV test is positive. So having that 211 as like something to have for when they need it, I think would be a great tool.
Nothing
Matt,
to
did you want to add anything?
Nope, same.
So what is the time frame for rapid start to be considered rapid? And I know, Ashley, you touched on this definition kind of spanning a few different things. So this individual asks, does it have to be the same day? And are there any contraindications or concerns for comorbid conditions?
So I think rapid start is not necessarily a time frame, but it's when you're starting HIV treatment on someone when you don't have a lot of lab work, example, resistance tests or potentially confirmatory HIV tests. So it may be someone who's known they've been living with HIV for a while and they come into your clinic and you don't have a lot of things to go off of resistance tests, but you're going to start them immediately as well. So it can look a little differently. Generally, it's, within the day or a couple of days of diagnosis. But I think the big piece is you have limited information to go off of. So the second part of the question is about comorbidities, and certain HIV regimens do have considerations, but there are 3 specific regimens in the DHHS guidelines that are recommended for rapid start because of their ability to overcome baseline resistance, to be well tolerated in kidney dysfunction, for example, to have low adverse effect profile. So there's 3 specific regimens that we use. There's some certain other blood work screenings that we do in HIV for other HIV regimens. So we're using the ones that you need the least amount of information to be effective and safe for the individual when you're doing rapid start.
We were part of a pilot program in New York State related to the uninsured care program, which is frequently called ADAP throughout the country. And the standard for that, we were in a pilot, but it became the state's way of approving people for ADAP right away 2 years ago, this month actually. And the standard for that pilot was 5 days was considered rapid start. But something when people ask us that now, we live and work in New York State. In New York State, like the benchmark is 28 days. And I don't even remember if that's 28 days to see a prescriber or to start medication, because we almost don't even think about it anymore, because now when it's 14 days, even when it's for patient-directed reasons, which we respect, it feels like a really long time to us. So all of this feels rapid compared to the old days, but in the initial pilot we were in, it was 5 days, but in New York State, the benchmark is 28. So any of this stuff is much faster than that.
So this next question comes from a clinic that, from the sound of the question, they're not co-located with a pharmacy. So in those situations, how do you recommend to clinics to carry meds for Rapid Start? They get a lot of pushback that they can't afford to have supplies for PrEP or ART before Ryan White or PrEP assistance would take over for that payment.
So I think a couple options. One would be if your organization allows sample packs. A lot of the pharmaceutical companies have like 7-day samples that you can have in stock for Rapid Start. Another option is if you don't have a co-located pharmacy, trying to partner with a pharmacy in your area that does do a lot of dispensing of antiretrovirals and potentially even going forward with a contract pharmacy would be another option. A lot of like it's state specific, but like ADAP in New York State has a way to turn ADAP on very quickly to pay for medications, and pharmaceutical companies do have programs to provide 1 month coverage, especially if someone who is uninsured as well. So you can call and get like a number to give the pharmacy to get coverage for that medication to that month.
Yeah, I fully agree with what Ashley's saying, and it's something that certainly when we've presented outside of New York State that comes up a lot. Michael may actually remember when we were at the National Sexual Health Conference at almost this exact time 2 years ago, and it's the most frequent question. But all of the things that Ashley mentioned those are the things that people can do, but especially when she mentioned like the drug assistance programs through the pharmaceutical companies, that's the PC way to say it. Like I call that like squeeze every penny out of them that you can get and make it work, because like they do have those assistance programs, which are probably potentially underutilized. They're not a lot of people know about them, but they are more generous than a lot of us would assume. And so you can, in most situations, and again, we want to be respectful that different states have different resources available. Even when a person is completely uninsured, we've been able to get them that first month through those programs.
The next question is regarding patients whose diagnosis has become AIDS defined. So are there any considerations with rapid treatment for those patients? I think you touched on, it's good to, that's a high priority, right?
Yeah, it's actually, yep, exactly, Michael. So it is a high priority, and there's no restriction or barrier with CD4 count. Yes, if your AIDS defined and your CD4 count is lower than 200, it may not get up to normal levels as quickly or ever, but antiretroviral therapy is definitely recommended, and recommended even in a rapid start situation. So usually when we're doing rapid start, we don't know if they're AIDS defined or not. We usually don't have their CD4 count because that's a blood draw. So we'll usually get that in the next 24 or 48 hours. But Matt had a great example, like, started somebody who was AIDS defined, somebody who had a CD4 count that was very normal levels, same medication, and they both work really well.
Thank you. I want to be mindful of your time, but we have 2 more questions. One question is, some of my patients have raised some concerns regarding PrEP, such as bone loss and other side effects that they would rather not experience. Are there any studies regarding long-term use of PrEP?
Yeah, so the decrease in bone mineral density as well as decline in renal function are things that we have heard a lot about, especially with M-tricytidine, tenofovir disoproxil fumarate, or also known as Truvada. There's another version of PrEP now known as Descovy, which has a different formulation of tenofovir or tenofovir alafenamide in it, that the way it's metabolized is a little bit different, and the risk for those side effects, specifically lowering of bone mineral density or renal toxicities, is much, much less. And that you're looking at the Discover trial for that, where it actually compares Truvada versus Descovy, looking at those 2 side effects, and showing to be better, statistically significant in not causing those side effects. Now, caveat, we don't really know clinical significance for decrease in bone mineral density yet. Yes, it decreases bone mineral density, but we're not seeing a correlation to increased fracture or a recommendation to do ongoing DEXA scans. So that's still to be determined, but Descovy does have less risk for those side effects.
Okay, and then, oh, sorry, go ahead.
No, it's okay. Some of our HIV positive patients who have come in have stated that they didn't go on PrEP before because they didn't want to be on ongoing medication at all, or for those reasons. And I don't like ever saying like, if you don't do this, this could happen. But like something that, we do think about in that situation is that when a person does become HIV positive, they do end up on almost the same medications in most situations. And so without like saying like do this, like without being super causal about it, it is something that when people are making that consideration and saying that they're concerned about that, it's something to consider. Like PrEP is something that you can do for as long as it's significant to you, or could even consider doing something like 2-1-1 for your seasons of risk. But you know, ultimately, if a person becomes HIV positive, they will end up on basically the same medication that they were looking to avoid. And so it's difficult having that conversation, but it's something worth considering anyway.
And that brings us to the top of the hour. So thank you so much, Matt and Ashley, for being with us today. For those of you who had further questions or would be interested, I know somebody is very interested in the emoji campaign, feel free to reach out to Jenny or I, and we can help facilitate that. Thank you so much, Matt and Ashley. We are now going to go to a 10-minute break before we have our next session. So feel free to stretch your legs, grab a snack, and we will be back at 2:10 for a panel discussion regarding providing sexual health services in the rural South. Thank you so much, everybody.
Good afternoon, everyone. Thank you so much for rejoining us today. I would like to introduce my esteemed colleague, Dr. Christopher Hall. Dr. Hall is an infectious disease physician, based in Santa Rosa, California, north of San Francisco, and once home to the famed Peanuts cartoonist Charles Schulz, where he serves as medical director of Face to Face, a legacy AIDS service organization begun in 1983, serving the geographically diverse surrounding Sonoma County. His 30-year career began in HIV/AIDS, working with the National AIDS Network in DC and National Hemophilia Foundation in New York City. Following medical school at Johns Hopkins and medicine infectious disease training at Brigham and Women's Hospital and UCSF, he was Clinical Affairs Medical Director for the State of California, Department of Public Health's STD Control Branch, and Medical Director of the UCSF California Prevention Training Center. Following 15 years of medical leadership roles with the East Bay AIDS Center and San Francisco AIDS Foundation and its Magnet Clinic, his current commitments include promoting the development of national STD program sector and developing innovative digital healthcare solutions in infectious diseases, including self-collect testing strategies. Dr. Hall.
Hi, Jenny. Can you hear me?
Yes, thank you.
Great. Thank you, Jenny, and thank you for that introduction. I'm really excited to be moderating this discussion panel today. It's a really exciting panel with four really esteemed and extremely qualified individuals to speak on some of the opportunities and challenges for doing STI and HIV care in the Southeast and in areas that we might call rural or geographically diverse. So I'm going to just launch into some intros of the four speakers. I'm going to go a little fast because I really don't want to take up so much time speaking myself. And then we've got some questions. I would encourage people, if you have questions, please put them in the chat so that with any remaining time we have, we can get those questions to our speakers. But let me just go ahead and begin with we have individuals from 3 states. We're going to start with Louisiana. And in Louisiana, we have Dr. Norma Porter, who holds a Doctor of Nursing practice degree from UAB, an FNP from Louisiana State Health Science Center in New Orleans, and a Master of Nursing from Louisiana State Medical Center School of Nursing. Dr. Porter is a certified adult nurse practitioner who has provided family planning and STD treatment for outpatients, including patient education, and now provides healthcare services for people living with HIV/AIDS and hepatitis C, in addition to PrEP and STD services at the Tulane Doctors Clinic. I'm going to go ahead and do the other intros, and then we'll have some questions for all four. So from Arkansas, we have 2 speakers. Michelle Green, first, has been a nurse since 2005 and has worked in the ED, the ICU, the Arkansas Department of Health, and in private practice. In public health, Michelle has been drawn to sexual and reproductive health care, and in 2015, she became a nurse practitioner with Planned Parenthood and worked with sexual and reproductive health services, providing preventive health services, STI care, abortion services, and transgender services. In 2019, in partnership, she opened Vector Health and Wellness, which provides preventive care, sexual and repro health care, transgender care, and pregnancy options, including pregnancy options counseling. In addition, in Arkansas, we have Danny Harris. And Danny is a prominent educator, public speaker, and advocate within the greater HIV community where he lives. In 12 plus years with Arkansas's Positive Connections program, he's developed and facilitated numerous community outreach, prevention, and empowerment initiatives for our care, working with multiple groups, including the HIV Arkansas Support Network, Arkansas HIV Task Force, the HIV Planning Group, and the Southwest Arkansas Northeast Texas HIV Coalition, as well as the Arkansas Ending the Epidemic Task Force and National Latino HIV Leadership Council. Danny has pioneered and facilitated the Positive Empowerment Project in Arkansas while connecting folks to peer support. From his project, he has developed the Empowerment Guidebook. And Danny tells us he is a 15-year survivor of HIV, successfully maneuvering Ryan White programs for HIV care and treatment. He is also a 4-time cancer survivor and is presently living HIV undetectable and cancer-free. His work has been highlighted in numerous places in Our Care's HIV, as Our Care's HIV Program Employee of the Year, named as Plus Magazine's Most Amazing HIV Positive People in 2016, POS Magazine's 2016 POS 100 list, and POS Magazine's 2018 POS 100. Many nice accolades there. And last but not least, hailing from the state, from where I actually grew up in Mississippi, is Kathy Garner, who is the executive director of the AIDS Services Coalition in Hattiesburg, Mississippi. That's halfway between Jackson and the coast. She has worked with ASC for 16 years and has experience in program development and implementation over a 39-year career as a city planner with an emphasis in grantsmanship, program implementation, and organizational development. Since 2005, ASC has grown from serving less than 100 clients annually to well over 2,000 annually through case management, housing assistance, HIV testing and outreach, PrEP and PEP linkage, and linkage to care. ASC is the provider of non-medical services of first and last resort for rural Mississippians living with HIV, also providing housing for homeless men living with HIV and another setting for women, including women with children. She is a member of the Mississippi HIV Planning Council Executive Board and received a National Human Rights Award by the San Francisco Gay Men's Chorus in 2017 and was selected last winter as one of the POS 100 women for her outstanding work in HIV/AIDS community. She was named Best Unsung Hero by Signature Magazine last year. So obviously this is a great group. I'm just amazed at all of that this group of 4 people has achieved and can't wait to hear from them. So I have a few questions I am going to ask, but then I'm going to check the chat and just see if there are other questions we want to add, again, with the time that we have. And I'm going to start with Kathy Garner, since I just introduced Kathy. And Kathy, I wanted to ask first, you know, you've done a lot of work as an executive director and in organizational development. And I wonder, what's your advice for those seeking to build organization in the Southeast and in rural areas? So by that, I mean, you know, attracting quality staff, board members, and support for your organization. As we know, you know, it takes all kinds of support to keep an organization growing and existing in these challenging times. And do you have any advice based on your real depth of experience?
Well, number one, thank y'all for inviting me to be here today. This is very exciting, especially what you asked me, because we just incubated a nonprofit in the Mississippi Delta. Some of you may know Cedric Sturdivant. We actually, part of my joke is that in order for me to go home, there have to be more of us doing this. And I think it is critical to have people who are mentors, who are willing to step out and help other people do the work that they hope to do. And for the reason Mississippi's Delta, you know, has all the things that everybody says it has, but there are no CBOs working with HIV north of Jackson. And so having Cedric as a friend first and then as a colleague has been fabulous, to be able to work him through that process. And so I think probably the best thing that I could say is those of you who have experience, be a mentor. Those of you who have dreams of having an organization, find a mentor.
That's great. You know, one question about that, Kathy, how is it working with organizations from other states? So you say, so north of Jackson, there really aren't any CBOs that are active, but then you think of Tennessee, and I just wonder, are the state lines really bright in terms of kind of walling off kind of collaboration, or can you work across state lines in the Southeast?
We do work across state lines, unfortunately, and I think my friends here who are attached to our state will say funding gets weird in trying to help someone. For example, we're unable to serve people in the Jackson metro area, even the part of the not the Jackson metro area, I'm sorry, the Memphis metro area, because it's a part of the metro funding. even though those counties may be in Mississippi. Do we serve them? Don't tell anybody, but we help. We just don't spend federal dollars there. So yes, we do collaboration with our friends in Louisiana, Alabama. Of course, we work very closely with Kathy Hires and her group. Kathy has been a mentor to me over the years. So it is difficult because everybody's formulary is different. The services that Medicaid provides is different. What Ryan White does is different. For many years, I was told by our state health department that CBOs could not have Ryan White Part B money. And so for many years, we weren't able to provide services that our folks really needed until I went to a meeting in DC where there was a best practice where the money was used together. And so I walked outside of the meeting and called our state Ron White director and said, the jig is up. I expect a contract home from DC. And so now we're providing housing and emergency services to the tune of about $400,000 a year through Ryan White Part B.
So that's saying there is a value to go into some of those meetings and rubbing elbows with people, huh? That's great. Well, Kathy, that's awesome. I'm going to just move around the group. And again, no reason why people can't jump in if you hear something that you want to chime in on. But Danny, I was going to ask you a similar question to what I just asked Kathy. Kathy brought up, if you can mentor folks, it's really helpful. And Danny, I was going to ask you about how do we, because you're such a healthcare ambassador. I mean, you are such, if listening to what I read, which is probably just the tip of the iceberg of what you've done. How do we recruit more people to be advocates and to be ambassadors for our service out in the community?
Are you asking in terms of from the healthcare professionals or from community, the consumers that are in the community?
Yeah, I guess, we do hear them sometimes referred to as consumers, but how do we empower them to be leaders like yourself? Do you have any advice around that?
Yeah. In Arkansas, there's not a whole lot of opportunities given to people that are living with HIV to better themselves as far as becoming an advocate. There's a lot of us that have been doing it for a long time. But as we look behind us, we don't see a whole lot of new ones coming in that are ready to step in. Now, part of that is because treatments have gotten better and people are quicker to just assimilate back into their old way of life, whatever that might have been, and don't see the need for advocacy or being an ambassador. But they're still needed. And we still, through our empowerment groups, we have built little small groups that have evolved into an advocacy network that is in turn helping to build the company that I work for. ARCare administers the Ryan White funding throughout the state of Arkansas. We have all the Part B case management offices. And so we are able to, these groups are able to empower not only themselves, but to make the program better for the future. And to be honest, when I first started this work 12 years ago, I was only about 2 years into my diagnosis, and I saw the disarray of the program. And it was my hope by entering into this work that I could help to make the program better for the person that comes behind me. And so now these little groups are kind of catching my vision and are becoming and doing things along those same lines, hoping to make the program better for the next generation. And as we do that, we are creating ambassadors. They may not be the kind that will stand up in front of a conference somewhere and make a presentation, but they'll sure enough fight for each other. Just to give an example, one of them, we had a young lady move from Minnesota into a small rural area in north central Arkansas. and she had no clue. She had no job, no place to live. She didn't know who the doctors were. And I called one of the members of the empowerment group, and they contacted her and helped her to find the right place to live, to find a place to where to go to the doctor, and the Ryan White Case Management Office, and now they're buddies, and they go out to eat once a week, and so that she would never stand in front of a group to speak, but she definitely is ready to be an ambassador for other people living with HIV. And I don't know, I rambled a lot.
No, that's great. That's great. I recall, providing PrEP services by telehealth, and one of my patients was in a very rural area in California and really was not willing to go to any services in his area because he felt like, could be a friend or a family member who might be driving by or working there, and it just wasn't going to happen. He was only willing to go to drive a distance, to get services elsewhere. But I felt like if I had, folks who I could put that person in touch with somehow to provide support, that would have been so much better for him. But so I think the work that you do it's amazing, and I don't think we have enough structure to support, right now, cultivating people to walk in the shoes that you've walked in, to provide the kind of leadership that you've provided. I think it's something maybe we ought to work on. And that's why when I read about your empowerment workbook, I think that's something that could be, utilized by other organizations or in other communities. It seems like you put a lot of this, maybe not in a recipe book, but you've done a lot of work to codify that. That's great. I think that's a good pivot to Michelle. Michelle, I think one of the things that was really striking about the work you've done is the way that you have integrated reproductive health services into the work, STI and HIV work. And so often we see that as kind of balkanized. You go one way in the clinic to get, we tell some of our women patients go one way in the clinic to get, your birth control or your reproductive health services, and there's another door for the STI testing and treatment and so forth. And that doesn't make a lot of sense, but it seems like you've done a lot of work to integrate that. Yeah. I think you're on mute. Try to. I think we're trying to get our mic there. Yeah, I still can't hear you there. If you like, what I'll do is we can go to Norma while you're working on your audio there.
I wanted to interject something too. Hi, everybody. Well, Michelle is just going to take one little moment. I'm just going to talk to you about a program that I volunteered maybe 3 to 4 times a year. I would go and do talks with them. It's the faith-based group in the communities. That works well with African-American communities because a lot of, they do programs, they have health fairs, they feed people on Wednesday nights. So you have a lot of traffic that comes from those communities. So what I work with are a group of nurses, and not all are nurses, some are just in healthcare, they could be a nursing assistant or LPN, RN. And they usually are the people that do wellness programs for that particular church. And I try to go into communities where they have like 3 or 4 churches working together. And what I do is provide them with information on prevention for STIs. I provide them on information on where to go get treated. I worked at the public health for 10 or 11, maybe 12 years prior to coming to Tulane Doctors Clinic. And so I provided them with all of that information on STI treatment, prevention, et cetera. And it plays right into the PrEP program. And right now in Louisiana, there's a group that's working on Black women in PrEP. And so I am able to disseminate information about that program. And it's not to recruit Black women necessarily to get on PrEP, but just making them aware of what PrEP is and how to go about getting on PrEP if that's, you know, something that they need or they feel like they would benefit from. So we have some of those initiatives going on in Louisiana. Now, COVID shut a lot of that down because I haven't spoken in a church in about a year. And in fact, a lot of the churches were not meeting in person. They were doing a lot of things virtually. So I'm looking forward to getting back to that because I felt like, you know, we did get referrals from those kind of from disseminating that information and, you know, get people some help that they needed. And I wanted to tell Kathy too that I went to William Carey. So I know she, that was my bachelor's was from William Carey in nursing. So I just wanted to share that information with you guys.
Great. Dr. Porter, would you say that were any of the faith-based organizations doing could you do any of that work while they were meeting virtually? Because I know so many churches have been, you know, doing a lot of their services virtually or exclusively. Could you do any of this work that way?
I did not do any of the work virtually because it took so many of the churches a long time to even get up and running virtually. I work in this was all volunteer. The area I volunteered in is not a highly sophisticated area, you know what I'm saying? So I think some of them now do have the virtual capability, but they are old school, so to speak. They like things in person. And so now they are starting to meet in the churches again. So I plan to go back and start to do that volunteer work as well. But even if I don't, I can always drop off things to the leaders of that little nursing wellness programs, and they can get the information out. Yeah. And so right now there's a big initiative to push the Black women in PrEP. And I want to get that information out to them.
Great. And NCSD just did a series on women in PrEP. I think it's so often forgotten that the way PrEP actually started years ago was, you know, we looked at heterosexual discordant couples who were seeking, you know, pregnancy and using PrEP, and that for those folks, I remember that was the way I offered PrEP before or around the time of 2012. I mean, that was really one of the gateways into PrEP. So it's an important reminder. But yeah, you're just making me think, you know, because with remote health and telehealth, you know, where that's one way of kind of overcoming stigma to a great extent because people don't have to walk into that brick and mortar, is there some sort of overlap between that and the virtual space with the faith-based orgs, and maybe that's something to develop. But that's a great reminder in our communities that those are institutions that are extremely important to work with.
Right. And also Louisiana does have the teleprep program available. And even some of my patients that are partners of patients that I care for in HIV that are on PrEP choose to use that system because they can mail out everything. They don't have to make a clinic visit and all of that.
Any other thoughts, Dr. Porter, on sort of what are some of the rate limiting steps to PrEP access in the Southeast?
Well, we work closely with our Ryan White community partners. It's the Central Louisiana AIDS Support Services, we call them CLASS, because they do walk-ins and patients can just walk in and get a test done for HIV, syphilis, et cetera. And they refer to us, like sometimes we can get people in the same day if they do have positive syphilis cases, which we've been having a lot of lately in Louisiana, in Region 6, I should say, in our parishes. But when I get that patient in for STI treatment, that's my introduction into PrEP and, you know, reviewing risk factors and offering them the program. And many of them, they have no idea about that program. And some choose to do it with me in clinic, or I provide them the information on the state program. Because with the state program, you don't have to have insurance. With Tulane is a private clinic. Therefore, you know, we treat Medicaid and we take private insurance. But if you're uninsured, then of course you would create a big bill. So for those patients, I make them aware of what other programs they can use to access that information, that care.
That's a great point. You know, I think that it's a common theme that a lot of patients think PrEP is for somebody else. You know, it's for somebody, you know, it's for people in the coastal cities, or if you're a woman, it's for men, it's not for me, you know. So I think there's still this way, and it was brought up, I think, in the last session, I think we're moving away from just an exclusively risk-based kind of formula for determining who should be in PrEP, and rather, if people come to us, or if offering it, discussing it with everyone, it would be an important.
And also, I'm treating hepatitis C, and I don't know if you guys are have those programs, but patients who are actively or have a past history of injecting drugs, I make them aware of PrEP and the benefits of PrEP. And some of those patients and their partners have taken advantage of it as well.
Okay, great. There is a question in the chat for you, Dr. Porter. How did you approach faith-based organizations in imparting sexual health information? Did you encounter any pushback?
No, because these are communities that I know people outside of work. So, the volunteer that I didn't come in from a organization per se. I came in as a community person, and really the ministers, I would always talk to them. I would make sure that I didn't cross any lines they didn't want me to cross. And when I talk about things, I always talk about prevention. I don't promote, they want to make sure you're not telling people to have sex, which is not what I'm there for. But, you just have to meet people where they are. I just always listen. I meet with the leaders. I want to make sure I'm within the boundaries that they want me to be in. And when I talk with the people that work on the health, the wellness programs, I provide them a lot of things is prevention, and I've given talks. In fact, I've had some of my colleagues from the public health department come in, and we would divide up, like I would speak with the teenage girls and he would speak with the teenage boys. And, we just kind of made it fun for the congregation, so they were not intimidated in any way. And, we were very respectful of what they wanted us to do, but still gave out correct information and provided avenues for these teenagers to get to public health, because they don't need a parent's consent, to get in. And I would tell people, let your kids come in, they don't have to be sexually active, because of course, most of the kids are not going to tell the parents they're sexually active. I'm sure Michelle can attest to this. But once I got them to my clinic, then I can really get all the information I need and get them the help that they need.
So it sounds like some of the pearls are approach the churches as an individual, not necessarily as an organization, and meet them where they're at, right?
Exactly.
So yeah, so listen to what some of their boundaries are and meet them where they're at. So that's great information. Thank you. And I think maybe we can pivot back to Michelle, because maybe we solved the audio issue.
I hope. Can you hear me?
Yes. Welcome.
Yay. Okay. So as far as integrating that care, it's mostly just been every time I see somebody, I ask them about their sexual and reproductive health. Just like I always ask people about intimate partner violence. It's one of those things that's important to destigmatize talking about things, so that it increases repertoire with patients. It increases their trust in you, and they might not be open to doing it the first or second or even the 10th time, but eventually they do, and asking that across the board. The primary care doctor here does the same thing pretty much. Whenever we see a person, if they're sexually active, we're going to ask them if they have had any partner, if they need STD testing, if they have any questions about their sexual reproductive health, anything like that.
Great. You remind me of, we developed a curriculum with CDC, like, I don't know, going on 20 years ago. And it was around some of the stuff, and the mnemonic was ask, screen, and intervene. And the thought was really just train providers simply to ask. And it's kind of what you're saying. Now, a lot of providers don't want to ask an open-ended question, right? Because, they're looking at their watch and want to get out of it. But the point is, just make it okay for people to share what they need to share, and remember to ask, because that's very permission giving in a clinical setting, when a lot of patients are certainly, they have the ideas about it, whether you're going to judge them for the issues, the sexual health issues that they might want to bring up. So that's a great point. It's just remember to ask every single time. That is great. And any thoughts, Michelle, about you've worked in the public health setting and you worked in the private setting, as many of folks here have, or as our couple of clinicians have, but any big differences in the Southeast, for instance, and working in public health settings versus working in private settings?
Usually as far as I've been able to tell, it has a lot to do with the time involved with everything. You know, being in private practice, I'm able to say, okay, so I want to set aside this much time to talk to a new patient. And inevitably, I'm going to talk to them about sexual health, every aspect of sexual health I possibly can. And you're not necessarily able to do that when you have, 25 patients on the roster. And in public health, it's the same way. You have so many patients you have to see because there's so many patients that need your help at that point in time. So it's really a matter of trying to winnow down and get all the information that you really know you need to get, and try and just hope that you've established enough belief in yourself that the person's going to come back if they need to come back, and they're going to call or they're going to ask questions if they need to.
Okay, that's great. Thank you, Michelle. And Kathy, I'm just going to return to you. We're at the end of our time, and this has been a really inspiring group. I think there's a lot of pearls here. And I think there's some ways that we can kind of build on the lessons you've provided us to maybe adapt some of the things we're doing at the national level to amplify your voices and, do more of what you have done that has worked. But Kathy, I just wonder if you have any, I don't mean to ignore Danny, but I'm going to go back to Kathy and just say, because Danny, it was great hearing from you too. But Kathy, I just wondered if you had any parting words for us.
Well, I would be kicked out of the school if I didn't say housing is health.
Absolutely.
We're the HOPWA provider for 73 of the 82 counties in Mississippi. And as you work with STDs, HIV, the whole quagmire of things that everybody in the South has to deal with, from poverty, racism, many isms, fear. We really have to remember that in order to overcome anything, we really have to have a place that's safe and sanitary to live.
Thank you for, I was actually one of my questions for you, and you landed right on it. And no, that's great. Housing is healthcare, and absolutely true. We think about the hierarchy of needs. We can't expect folks to be working with us on some of these other issues if these really primary issues are not addressed. And you have done so much to work on housing where you are. So hat tip to everyone here. Really amazing group. Thank you so much for your time and participation. And again, I think that we've learned so much. So I'm gonna turn it back over to my colleague, Jenny, and really appreciate you all.
Thank you very much.
Thank you, Chris. So we have some additional questions I'm seeing come through here. How does being in the Bible Belt impact sexual health services where you are? And we can go around the panel.
Well, in Louisiana, let me just say that sex education is not even taught in the high schools. That's how prohibited. People think that if you talk about it, you're promoting it with teens. And there's been some effort by some of the educational leaders to incorporate some of these programs into like physical, PE. When they do PE, they're talking about more of body development and all of those things. So, we still have a ways to go. Just one day at a time, working with community partners. We work with, Part D classes, the Part D partner that we work with, because they do rapid testing. They make referrals to us. We rely on Office of Public Health, because also they do hepatitis C testing, syphilis testing, all STI testing. They treat, but they also, if they get an HIV positive person or a Hep C patient, then they refer to us. So we have to all work together. And also working with those non-traditional sections. I just can't talk about that enough. Sororities, fraternities. We've been asked to come and speak to fraternities in the African American community and sororities, and just getting the information out and creating ambassadors that, you know, they don't have to know the medical knowledge, but they can refer patients, refer people for help and know where to refer and how to get that help.
In Mississippi, we are very fortunate to have something that our legislature has come up with called abstinence and abstinence plus. The difference between abstinence education and abstinence plus, it makes it sound really sexy, but the difference is that in abstinence, you cannot say condom. And in abstinence plus, you can say condom, but you cannot bring one. If that doesn't give you an idea of the state of sex education in Mississippi, I'm not sure, except for the fact that you cannot take a condom into the state capitol rotunda, but you can wear your gun on your hip. I have been asked to leave the rotunda with my condoms. So that's all. Enough said.
That's the same thing in Louisiana. When I do sex education with a school, I can't bring any of that with me. So.
One of the things I was going to add is that I've been in so many different states, and all of them claim to be in the Bible Belt. And so I've been as far north as Indiana. They say they're in the Bible Belt. I've been in the Northeast. They say they're in the Bible Belt. Everybody claims to have that buckle over their state. I really think it's not the Bible, that it's other issues that are at play. Because to be honest, when I have spoken in churches, I've had a very welcoming approach. And most of the pastors have told me, speak to them like you would if you were out on the street, because when they're out on the street, they're going to talk like that. And I've been given a lot of freedom in my opportunities to speak to different groups around the state. So that's not to say that we don't operate under some very oppressive guidance. I don't know about carrying the condom, but you can't carry a package of lube in our state capitol. We can't use our state funds to buy our lube to give out to go along with the condoms. So
come see me, Danny.
All the states are the same. Oh, I go to the local club and ask them to do a fundraiser, and I buy it through their funds.
Michelle or Dr. Porter, do you have any thoughts?
We do as much outreach as we can. I usually try and talk to at least a couple of Girl Scout troops a year. I have a friend who's a Girl Scout leader, and I do talk to them pretty often about sexual and reproductive health. I have a pretty good relationship with the Unitarian Universalist Church in the area. And we do a lot of kind of outreach in that area. And we are kind of getting a little bit of a reputation. So we have had quite a few younger people come in as far as like the Fayetteville City school system, the high school system, because we really are pretty loud and we try and do a lot of outreach. So that's kind of how we're trying to work around the Bible Belt thing. But we are an abstinence only education state. So that makes it kind of tough.
Same here, abstinence is what they promote. But one good thing in Louisiana, though, teenagers can't come to public health without the consent of a parent. So, you know, if I get them there, and what I do in churches, I said, listen, just, you know, your child doesn't have to be sexually active. Just come and get a checkup, get to know the provider, so that when they reach that point, they have a safe place to go to get correct information and get the care that they need. And that's just one approach to kind of ease the tension with parents and get kids out to the health units, you know, because I think that's a great way of reaching a lot of people, because that, you know, the funding, they don't have to have insurance, or they can come in without that parent. Also, I wanted to say too, in Louisiana, that they did start a needle exchange program, which I'm sure, I don't have the stats on that, but I'm sure has helped, because I do see a lot of, in my HIV population, as well as my hepatitis C population, we have an increase in IV drug use. And that needle exchange is not statewide, but it is in Region 6, I think all the parishes except one, because I had one patient said that that was not available to him, but I was able to give him other resources. Because some people, you know, they use to every day or they use whatever, but they need to be able to get clean needles and not have to share needles. So that's one thing that has helped us hopefully decrease the transmission of HIV and hepatitis C.
Congenital syphilis rates tend to be higher in the South. Do you have any insight on that and kind of what is happening around congenital syphilis in the South?
Well, we just did a work group for that very reason, because I'm in Region 6, which is Central Louisiana, and our rates have gone up tremendously. And we have a work group working with other agencies like our rural health clinics, OPH, other community groups, trying to determine what's going on. I think that we're just doing more testing, okay? And, you know, again, we have class can do rapid testing for syphilis, and we also at this clinic have rapid testing for syphilis. And so if somebody gets a rapid syphilis case, they can pick up the phone and call, and we will try to get them in the same day. And if they're in our clinic, I will try to squeeze them in. It's getting harder. We just lost a clinician. Well, she retired, so well-deserved retirement. But it's going to be a little tight until we can get somebody else on board, but we get those patients in, try to get them treated. Of course, the DIS workers within public health will interview that patient to try to get their contacts and get them in for treatment as well. Also, I've noticed in this Central Louisiana area, we have a lot of transient people just kind of coming from everywhere, like Texas, you know, even my patients, you know, that re-enter care, they'll say, oh, I went and I lived in, one guy just told me West Virginia for about a year, I took a job there. So people are just moving around a whole lot more. And we have an increase in homelessness as well. You know, a lot of meth users, and sometimes they go in groups, it seems like, and, you know, they're just kind of camped out somewhere. And that's what I've been seeing here in this area. So I don't know if that's where you all are, if that's what's going on, or, you know, maybe you can speak to that.
It's very similar for us in Mississippi, except I think you're welcome, Louisiana and Arkansas. We've outdone you on most everything. We're, I think, third in the United States in syphilis and chlamydia, and number one in gonorrhea. And, you know, I think there's a direct correlation between can't say condom and, you know, we have the most unintended pregnancies and the lowest use of protection. So, you know, it's not a real hard math to see that it's just not working.
Michelle or Danny, do you have any thoughts?
No, I agree. I feel like, you know, I talk to my friends at the health department a lot, and I do feel like we have been testing more in the state. Of course, we are kind of at a 20-year high for syphilis this year. So I think recently there were people that weren't being tested, especially over the last 2 years or so. But I do think prior to that, testing was increasing, and I think it's going to continue to increase. So I'm hoping that one of the reasons that it's up is because the testing is increases, and that kind of is what it's sounding like. But I also think we need to make sure to continue to be diligent about talking about protection and regular testing.
Absolutely. And I think we've done a really great job of outlining the challenges, and there are many. And I think I just give so much credit to each and every one of you for continuing to stay in the field and to work toward mitigating all of these challenges. But let's talk about some triumphs. So tell me a success story, tell me a workaround, tell me something positive where you feel like, you know what, today I made a difference. Do you have any of those stories, any of those triumphs, anything that keeps you going?
I think our incubation process with nonprofit led, the only nonprofit in Mississippi led by a person living with HIV in the state. I think that, and then there's our safety delivered condom program, where we deliver about 120,000 condoms free unmarked packages every year. So condoms and Mentor. So
Incredible. Thank you.
We had an APN student, a family practice APN student, a couple of months ago, and they shadowed us for probably about 3 or 4 months. And he said that he learned a huge amount, and that it really opened his eyes. And by the end of it, he was asking every single solitary patient if they needed STD testing, and he felt really comfortable talking to them about it. So I would have to say mentoring and preceptorship is probably one of the biggest and long-lasting impacts we can make.
Well, we recently instituted, we've always done extragenital testing, but we're trying to do it in a more systematic way. So we are in the process of incorporating a program where the patients, while they're waiting in an exam room, can answer their own questions about, what parts of my body do I have sex with? And that kind of generates a little card that will tell what testing that they need. So that's one positive thing that we're doing. And the staff is on board with that. So we're hopefully identifying more infection, treating them, and preventing the spread of those infections.
I was going to mention a couple of things that go right along with what we're talking about. One of the things that COVID caused us to do was it forced my company and my team to spend more time evaluating what we did rather than just being out in the field. Go, 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 go. We had the time to back up, evaluate, and devise some new strategies. And one of those was our online activity, using social media and our website in order to do the self-testing and the prep enrollment process being able to be started online and recruiting from off of the online dating sites. And we're at a point where we're seeing 18 to 20 people every month being added to our prep roster. And to me, that's an exciting thing to think about. And the little condom club that we have began and instituted off of the website has taken off faster than I would have ever anticipated. And I'm going to make me a shirt with the condom club on it. But the other thing that I wanted to mention was that when my phone rings at 10 o'clock at night or 2 o'clock in the morning, and I look down and I see somebody, one of my clients from one of the empowerment groups calling, and when I see that, my first response, as is my wife's, is to be one of aggravation. Why is this person calling me? But then I had it happen the other night, and the thought came to me that even though I was in that dark room and I'm laying there in the bed, the phone rang, there was somebody that needed a little light. And that to me is the most positive thing about everything that I do, is that if I can just be that light for just a moment in that one person's life to keep them moving on one step further, then at the end of the day, when I'm done and I go home, however I go home, I can say it was a good life and it was worth it. Was that too deep?
No, I think that's wonderful. I think that's so
or
powerful.
depressing?
No, thank you so much for sharing that. I think that's really powerful. So how, speaking to, innovations developed in response to COVID-19, have you had to do that and sort of innovate on the fly? And if so, have you sustained any of those innovations moving forward?
Well, we had to use telemedicine, which was on a back burner. I think they were planning on doing it maybe in 18 months, but we did it within a month, I think. And so we're still using that. And it really serves our community well, because I have patients that drive as far as an hour and 45 minutes to come and see me. So we have worked on getting labs. So like if they're closer to outside of Natchitoches, trying to identify labs for lab draw places that are much closer to their homes, and I can still do my visit. So the same thing is we're trying to institute for our PrEP programs as well, so that they can turn in the labs if they're living like an hour or so away. They can drop the labs off there. I can get the lab results, have the televisit with the patient, and be able to send out their medications. And we also, for those remote areas too, we use a lot of the mail order pharmacy. We have 2 or 3 that we work with, and they carry the drugs that we need, and that works well for the patients too, and provides them with the medications they need. And they work a lot with Medicaid. I take care of a large Medicaid group, and they work with the formulary. So
it's very difficult when you're during COVID, when you have an outreach group that can't go out. So but I will put my folks, they did it. The support group is bigger and stronger than it's ever been. It has encouraged them to do education in ways that they've not done it before.
Right.
So, you got to have the passion. You've got to look. If you want to do it, you can find a way to do it. And they've done a fabulous job. And some of the things, we have people who continue to come to support group. And it's broadened the availability of the support group to a larger area too. So, yeah, so good things.
And somebody talked about that syphilis cases, we've seen the numbers go up. And just remember too, during COVID, people were not able to get the testing done that they were getting before. And I think what we're seeing is just some of this catch up, increase in cases and stuff. That's what I suspect. So hopefully those numbers are going to come back down. But I think that there was like 5 or 6 months where people didn't have access to those drop-in places to get the testing that they usually were able to get.
That's wonderful. Thank you for that. It's a really, really good point. Can you talk to me a little bit about stigma and safe places to access and receive services? And what does it mean to build the trust of the community, and particularly the LGBTQ community? What does that look like? How do people know which providers are safe to go to and sort of trusted? What does that look like where you live and where you work?
Well, our clinic has been here, oh God, it would start out with the state hospital. So we don't advertise as an HIV clinic. That's number one, because in a small community, people are very afraid of being identified if somebody sees them going in this clinic. We're infectious disease. We always say we treat hepatitis C. We never just say exclusively we are HIV, and I think that the patients, what they've remarked to me, we have a case management group. They're very connected to this clinic and they trust the people that are here. They can pick up the phone and call directly and speak with whatever services they need to speak with and get a pretty quick turnaround. So I think that takes years to build that kind of trust and rapport with patients and communities. And I think that it's always important for clinicians to do volunteer work so the community knows who you are and what services you provide, and not to do it as, advertising. Like I never say I'm from the HIV clinic. I always, talk about prevention, so because unfortunately, in some communities, I mean, there's so much stigma still associated with diagnosis. And, we never want to make people feel uncomfortable in accessing our services. Does that answer a little bit of what you're asking?
That's great. Other panelists?
We do a lot of outreach and we're really present in the community. We've also kind of collected some contacts of other providers, of other places that are LGBTQ friendly. And we have a really strong network of support in the area. And that started a long time ago, but we were really pretty outspoken when the group that's currently Vector, when we used to work at Planned Parenthood, and we always went to marches. We went to Little Rock for the health fairs and the the Women's Reproductive Rights Day, and we always march at Pride. And honestly, just walking into the clinic, you're either going to know right away if this is, you know, oh wow, this is a place for me, or yeah, I need to find another provider, because it's all rainbows and flags and just people's rights and healthcare rights. And we outreach to the scouts and outreach to churches and the schools in the area as much as we can. And word of mouth has been really huge. Also, the website and Facebook, that's been pretty big, so people can find us pretty easily.
That's wonderful. Thank you. Danny, do you have any thoughts?
Well, I was going to say, I want to echo what Michelle was saying. It's being present and available. I know I don't work in a clinic. I work out in the community. That's where my work is done. I have an office in the clinic, and I'm sitting in it presently, but I'm out in the community. And a lot of people that I come into contact will equate our clinic with me. And their trust is built upon the fact that they feel they can trust me. And so that's the one way I can help deal with some of the stigmas that people place on the Ryan White work and the HIV work, is that they know it's safe because they feel safe with me. So it's that need to be present and that need to be available in the community. The other thing is with those in our empowerment groups that are living with HIV, and Kathy may understand what I'm about to say, a lot of them are dealing with internalized stigma that they're putting on themselves. And a lot of the work that we do in those empowerment groups is working through and sorting through and unpacking that burden that's on their shoulders so that they can live a happy life. And so stigma is still here, and it takes just working with it.
Well, stigma is killing people. It's not HIV. And you're right. One of the things that we do is that I try to make sure that our staff is reflective of the community. Nobody wants to hear about condoms from a 61-year-old lesbian. That's what I have discovered. So we try to make sure that that we have women who are women of color, men of color, gay. I have a big old rainbow of a staff, and the fact that they're able to even just walk into a room and be more accepted than I would. I got the old lesbians down, but everybody else, I try to get somebody else to talk to.
That's helpful. That's also very funny, Kathy. We have talked to folks who have said, I really can't go to that clinic. They're going to tell my business, or I really can't, if I go there, it's the health department and they're going to call my aunt who also lives in the same town. How pervasive is this? How is this anecdotal? Does this happen? Can you tell me a little bit about, is this a challenge where you live and work?
It is real. When I worked for public health, I had to go to small towns, and one town is specifically probably, I don't know if the population was even 25 or 50,000, but people do talk. And so I think that a lot of effort has gone into making sure that, things are put in place where patients don't have to worry about that. Now, I don't work for public health anymore. And in our clinic, I have patients that travel from Shreveport, which is 2 hours away, and there's HIV clinics there. But they travel because they may be a minister, they may be, some big person in that town, and they cannot be seen going to that particular clinic, or even if it's a private provider, they just are not willing to take that chance. So they travel 2 hours to come and see me, and that's why telehealth has been so tremendous, because we try to ease the burden for that patient. And I'm so glad that Kathy mentioned about having a diverse work group. That is so important. Even when I take my children, well, they're adults now, but I don't want to go in a clinic where I see nobody that looks like me. It doesn't have to be the provider it looks like me, but I want to see other people just to give me some comfort. And I feel my patients, they feel the same way, So I think it's always important when you're running an organization that you think about that, that your workplace should reflect the community that you serve. So thank you for saying that, Kathy.
The reason we started doing HIV testing in the first place about 14 years ago was because in Mississippi, if you are a man and you go to the health department, you've got an STD. There's not any other reason for you to go. And so the people who most needed to be tested were not getting tested. And so we did that to provide a safe space where your cousin wasn't at the front desk. I think you and I have talked about that before, Jenny, that apparently everybody's cousin works at the front desk of whatever county health department you're going to. People have to feel that they have a place that is safe. And I'm so proud that my staff has made all of our places a safe spot to be.
It's extremely powerful. Thank you. Danny or Michelle, do you have any thoughts?
Well, the one thing I hear is in connection with, like what you're saying, is in with the health departments, in these small communities, your auntie might be working at the health department and you don't want her in your business, or the only provider that's in your town is a longtime family member or longtime friend of the family that is a deacon in your small town church. And so that worry about people being messy or being nosy in your business and not being able to be confidential is strong in those areas. But I haven't heard it from my groups as much about organizations that are doing HIV and STD testing. I have heard it said about specific individuals that they didn't trust this person because they see them out at the club every night dancing and doing their thing, and they're afraid that they might share that information, but not as an organization as a whole. So I think it's kind of limited. I don't think it's pervasive, as you said.
Also, I just wanted to mention, just put a plug in for our clinic. We started maybe a year and a half ago offering one evening clinic. We had two, but because of staffing, we had to cut back. And that has worked so beautiful. That clinic is always booked because people that have lay jobs sometimes don't get paid if they're not at work, or they're fearful that they may lose their job if they have to take off for a doctor's appointment. So that has gone over very well. And like I said, as of now, it's 1 day a week, but we're always booked in those slots. And we offer care up to 6:30. So
that's wonderful. I have a question about telehealth. Are there any challenges related to broadband, to access, so that like the network telecommunications, are there any areas where that's an issue of like, I can't get a signal, or I don't have the wireless, or what does that look like? What does telehealth look like in rural areas?
Sometimes it's very hard because you'll see the thing spinning, you can see the patient, then you won't hear them for a long time because we don't have, what is the bandwidth, I guess, that's set up for it. I'm not technical at all. But anyway, what happens in that instance though, because most patients are using their cell phones. And so if I can't get the connection, but I've already established a connection, you can still bill as long as you complete the visit. So sometimes I have to hang up and call the patient and complete the visit, but that did work. So.
There are lots of places in Mississippi where you cannot even use your cell phone. And many of the clinics are just now beginning to do telehealth. One thing that COVID did do, and I'm very happy, and Dr. Porter said about it, it pushed clinics to do. I had my first telehealth visit last year that I ever had, and it was very exciting. So it did push, but the infrastructure is not there. So I'm hoping with some of the infrastructure monies that are coming up as a part of the COVID relief that'll actually, with the infrastructure changes, that's going to help us all.
So we have a couple questions here. One is, can you speak on self-collection kits which could assist in reducing barriers?
In Louisiana, we do have a telehealth program, and it is self-collection. So I'm not affiliated with that program, but I know that a lot of people do use it. So now, with us, like our program, we're trying to accommodate those patients that live a long ways away by trying to connect them to a drop-off point where they can go get labs collected somewhere else instead of driving all the way to Alexandria. But I don't have the details of the telehealth program for Louisiana, but I know that it is self-collection.
I don't believe that's used a whole lot here. It's just not an availability for folks in Mississippi.
Okay.
We do the self-testing, the HIV ones. I don't know that we're doing the self-collect on the telehealth, but I know that we do the at-home self-test, and we have a whole system in place where a person can order it from online. It's mailed to them free of charge, and we've only found funding to do the HIV side. If we can find funding to do other rapid tests, we'll expand a little bit. But we average about 30 to 40 tests a month on our at-home HIV testing, and we've discovered at least 3 reactives in that period of time that we've been able to link into care.
Wonderful. And I know we're kind of getting to the end of our time here, but what do you think that the country has wrong about where you work and what you do? There are certainly a lot of stereotypes about the South and the rural South, and and what, for better or worse, what do you want the country to know about the work that you do, and just the challenges you've been able to navigate and all of that? What do you want people to know, or what do you want to correct and sort of straighten out the record about the work, about providing sexual health services where you do?
I guess they're going to make me go first. I did ministry for 25 years, and prior to HIV. HIV brought about a lot of changes in my life. And so I've had several people say, "Why did you get out of ministry?" And my response is, I only got into ministry 15 years ago. And so the truth of the matter is that I did not know what serving people and ministering to the needs of people was really all about until I started this work. So if I want to set the record straight, this is where I should have been all along. And I have learned to find a sense of purpose and significance that I could have never found without it. Record set straight.
I love that. Thank you so much, Danny. That's really powerful.
As my brother would say, what he said. I think it's not to get religious, but preach the gospel, use words if you must. I think that a lot of people don't think that we are even doing outreach in the South, because why wouldn't things be fixed like they are in New York or California? I don't think they understand the quagmire and train wreck of barriers that we have that they don't even dream of every single day. So that's probably the most important thing, besides the
Oh, Kathy, you're muted for your last words. Besides what?
Preaching the gospel thing.
Okay. Thank you. Dr. Porter?
Well, I think that living in the South all of my life, we learn to work with the barriers like poverty. I mean, I think that some places just don't even have any idea of trying to raise families on such a minute amount of money, the lack of resources that are available that they probably don't even think about, phone services, government phones, the limitations of what can be done with those phones as far as doing the televisits. There's just a lot of barriers to overcome, but people are so receptive and appreciative of what you do, and I think that if you're in this job, it's because you love it and not because of financial reward or anything like that. It's something that, you have a desire, a ministry, or a passion for. And I've been doing this type of work for I guess maybe 40 years now. So again, I feel like it's my missionary stuff. I get more satisfaction from this than sitting inside of a church, even though I go to church too, but it's just my work is my church,
I think that's really incredible. And I think that there's such a passion for the work in the sexual health field that I feel like everyone's just like, we feel you and they understand. And it's just, that resonates, I think, so deeply with people who work in the field. And it's like, once you catch the bug, they say, and you get in, it's rarely do you leave. You have some, you become a lifer once you get into sexual health. And I see why. I see why this is the case. We do have a question about at-home testing. I think this is probably for Dr. Porter. What are some of the panelists' experience with self-collection for GC, CT, or syphilis? What are some suggestions for implementation in programs or in outreach settings, distribution of any type of self-test kit?
Now, in the clinic, we let the patient do their own rectal. They could do rectal tests themselves. We instruct them on how to do it. But I thought they were talking about mail-in testing. Is that what the question's in reference to, or? See, yes. I'm not really the person to really speak to that because I don't work in that area. We do all of our testing on site. But self-collection, we do the oral swabs for the patients and we let them go to the bathroom and do the rectal collection. But I can't really attest to the other program. The telehealth is what I think they're talking about.
And what are your thoughts around, if you had to implement such a program, what would you prioritize? Which populations or subpopulations would you prioritize? This is for the panel, if you were going to implement a self-collect testing by mail program.
Young Black males.
I didn't hear that, Kathy. What did you say?
Young Black males.
Yes. Okay. I think that's a high risk group. Definitely that they don't like to come in for care, but I like the idea that somebody mentioned about dating sites. I think just putting information out where people can get it that may be at high risk, and letting them be able to go to websites and get the instructions there and follow through. I think is a great idea.
We got 3 people in prep last week off of Grindr.
Can you tell us your process for that, Kathy?
I have a staff person who sits around with with Grindr on. I'm not on Grindr, so I'm not really sure how that. What they do is they pick an area, and they say we're doing testing. It's sort of like, instead of having sex, you can come have an HIV test. And so it pulls people in, and I think some of that's word of mouth too, because it's very expensive to actually advertise on Grindr. So we actually try to be able to sneak through comments occasionally. But we literally have a cell phone that is for outreach that has Grindr on it.
That's wonderful. Danny, do you have any thoughts?
That we do the same thing. I've got a staff member that he does all of the, his funding comes through one of the HRSA grants for PrEP, And so he uses funding from that grant to do advertising on Grindr and Scruff and something else. I don't know all of them that he does. And he creates the advertising and puts them on there for a certain period of time. And he'll just, it's just, I see the orders for the test kits and the, to get the at-home test kit or one sent to them in the condom club, all of those orders and prep, I see them coming through, and there's 7 or 8 a day that are coming in from different sites around the state where he is running those ads constantly. We get a few off of Facebook and Instagram, not as many, but we still get a few off of our boosted work on there. But we've had a lot of success in using those types of ways, especially during COVID, where we could continue outreach and continue getting things out to people to help protect themselves.
Thank you. And we have a comment. I feel the same way that in SF, the Latino and Black youth men are often forgotten. Absolutely. What is, having been in the field for some time, what is a good trend a positive trend? What has gotten better in the last 5 years, 10 years, 20 years? What has gotten better in terms of sexual health services where you work? And what are you hopeful about going forward?
Well, I think that we're reaching more people for sure. You know, I think that services used to be very underutilized, and I find that people know now it's good to get a checkup. I think we have, when I go to the faith group, you know, everybody needs to get a checkup, you know, and I think people are just more open to that. And so that's what we try to promote. Go get your checkup, go get checked. And I think more people are doing that.
I was just talking to the director of operations 2 days ago about this topic, that when I first started this work 12 years ago, we had no funding for condoms. And I can remember going to special events, and I would go around the room and find out who had condoms left over, if I could bring some back to help get to our clients in the offices. And now we're sending out 100,000 condoms a year. That part has gotten tremendously better. And I think that there's other things here in Arkansas that we could also speak to, but that one immediately jumped up to my mind when you said that.
I think what gives me hope is that when I first started, everyone that we worked with who had just been recently diagnosed thought they were going to die. They were, you know, preparing for the end. And now people live, and the medicines are so much better, and we're able to actually start someone immediately on medication that in the past, you know, we'd have to wait 1.5 months or 2 months, or until, Dr. Porter probably remembers this, you know, until their T cell count got so low that it was time. So the fact that we've been able to, and this is advocacy that's done this, a lot of it is medical, but a lot of it is the actual advocacy of people living with HIV saying, I don't want to take medicine when my T cell count's 200 or below. I want to take it now. And so I think the advocacy and people live.
And speaking to that, Kathy, it's just a game changer. I did HIV back in the early 80s, mid 80s, and I worked with the clinical trials group at that time because, you know, we had no drugs. And I was only early 20s, and to watch people die in my own age so quickly, you know, and then I was out of HIV. I did diabetes and internal medicine for a while, and then I came back into HIV, and to see the treatments that we have now, guys, it's just phenomenal. And the thought of having an implant like an Nexplanon, you know, that we use for birth control, to be able to be inserted under the skin and have a treatment for a patient that doesn't want to take medications every day. It's just, it's just going up. We're headed up, and I'm just so happy to be a part of it.
I apologize, I was on mute. I just wanted to say that was really great. Thank you so much. We have a really important comment in the chat from Dr. Andrea Apostolou, and she says critically important is not forgetting Native youth in Native communities. Can any of you speak to working with Native youth in Native communities?
Well, I can give the talk because we have a Native community only 45 minutes away. And I've given health talks there, but they have their own clinic and they have everything well under hand. I think they do STI testing, and they also use the health unit, which is in the same town. But that's my connection to the Native American community here locally.
Very similar, the areas where we have indigenous folks have their own bubble a lot of times, and we do education, we do some exchanges, but they're seem to be very self-sufficient with funding and programs.
Thank you so much for that. Well, I just want to thank all of our panelists and Dr. Chris Hall. Thank you so much for your time and for really giving us a really clear picture of what it's like to provide sexual health services in the rural South. If any of our participants are interested in asking you questions or following up with you, are you comfortable with them emailing you and connecting? Great, thank you so much. We'll make sure that everyone gets your contact information. Thank you guys so much. So we're going to go ahead and take a break. We're going to start again at 3:45. So 3:45 Eastern, we'll be starting again. Thank you so much. Good afternoon, everyone. You have made it to the final presentation of the Clinic Plus conference here at NCSD. Last but certainly not least, I'd love to introduce my colleague, Jeremy Beshears. He's the Director of Training and Technical Assistance at the St. Louis STD HIV Prevention Training Center. With nearly 20 years of experience in sexual health, Jeremy is dedicated to educating community partners on innovative sexual health principles and how to operationalize them into their practices. He's a national conference presenter on trauma-informed STD HIV prevention and PrEP implementation. We are honored to have him here. Jeremy, the floor is yours.
Thanks, Jenny. Thanks for having me. Share here. Thanks everybody for sticking around today for the last session. All right. So we're going to talk about trauma-informed HIV and STI prevention and care and how we can implement that into our clinics. This training or technical assistance package is a package that we offer through the Prevention Training Center that is typically done over 2 days. It's 4 modules. So today we're going to get kind of an overview of the principles and of the training. So just kind of keep that in mind as we go along here. Here's kind of what we're going to go over today. So we'll talk a little bit about some historical prevention modalities that inspired this curriculum. We will go over the principles of our trauma-informed prevention principles. We'll talk a bit about the intersection of trauma-informed modules and shift to sexual health goal setting. That's going to be a big one and one of my kind of real passions when I do this training. We'll talk about how do we identify trauma-inciting barriers in our clinics, and we'll discuss what training and or technical assistance options may be available for you and your organizations, and how we work to apply the principles in your clinics. All right, can we talk? My friend Joan here is going to help me out with this. I just want to start by saying, you know, when I do this training, I always let folks know that, you know, this is a safe space. This is the time and place to ask questions that maybe you wouldn't feel comfortable in another setting. So, you know, I do have a little bit of time set up for questions at the end of the presentation, but I certainly value, you know, the power of discussion and sometimes debate. So I do encourage you to ask questions as we go along. I'm happy to answer those. Put them in the Q&A box. I think I did see one here in the chat. So this training is only available through the St. Louis Prevention Training Center currently. However, we are able to do it outside of our kind of 6-state region. So we can talk about that a little bit more in the end of the presentation. All right. The other part about the Can We Talk is that, you know, in this training, I'm going to ask that, you know, folks, you know, think about things critically within their organizations, things that can be tough, and, you know, things that can be sensitive to some folks. We'll also, of course, be talking about trauma that may affect our patients or that may affect us as practitioners. So, you know, again, this is a safe space, and I thank you all for being here. All right, so the need for trauma-informed prevention. This model I created with a former colleague of mine, Michael Gendernauer, the kind of base, the base of this training, and it has certainly evolved over the years. But you know, when we worked together, we realized that you know, there was this sort of antiquated prevention modalities. You know, we've had so much innovation on the care side of things and treatment side of things, and you know, we have done prevention work largely the same way for the last 40 years, and it's kind of come from a place that was fear-based, reactionary, and my hope is that as we chat today, or if we chat further with the organizations, that we can kind of move forward in our prevention and think about it as how can we innovate the prevention system. And that seems really overwhelming, but I think as I kind of talk through some of the modules here, that you'll be able to understand that it's not impossible, and we can change the system within our organizations, even if we're not doing it on a huge scale at first. So this example here in the picture is one of those kind of prevention modalities I'm talking about. Bang, you're dead. It's meant to kind of be a scare tactic for folks not to get HIV. There were also very few sort of trauma-informed prevention models. We have a lot of models for trauma-informed care, but the prevention side of things was sort of left out. So, how do we interact with our patients and our clients in a trauma-informed way, on the prevention side? Dennis Fortenberry does some great work in Indiana. There are, certainly other folks, but there is definitely a lack of a, actual model, actual trainings, actual technical assistance programs that I really think that organizations need. We're now trying to re-engage patients as clinics scale up their services post-COVID, right? We've done a training with one of the clinics that I work with closely recently. They're trying to figure out, how do we get back to a place where we can increase our patient volume? How are we making sure that we're providing the best care? How are we making sure that we're innovative? And where is the intersection of all of those pieces? We're also at a place, I'm going to scoot myself over here a bit, where we have an influx of new staff after COVID. I was having a conversation recently with someone from our health department about a big kind of hiring boom, I suppose, of folks. And I think for a long time, at least in St. Louis, we had a sort of pool of workers in the sexual health field, and you oftentimes saw people kind of moving from agency to agency, but they had that sort of baseline knowledge and that experience that is really important when we're working with folks in the sexual health field. And now post-COVID, I think it's a different scenario. We're hiring folks from outside of the field with less perhaps STI and HIV experience. I'm certain still great experience, but maybe folks that haven't worked in sexual health. So this is a really great time to kind of reevaluate and figure out what we can do again to innovate care and engage patients. And I think incorporating trauma-informed models is really important. And the last thing is intent versus impact. And this is the first of one of those things that I find sort of difficult for people to talk about when we do this training. I've been in situations in former roles where something happened and the response was, well, there were no bad intentions, or I only had good intentions when that person said that, so on and so forth. And I certainly appreciate that, but I think now we really need to think about the impact that our words, our actions have on our patients. And it is difficult, to think about like something that we have done perhaps in our clinics or in our practices may have caused trauma within our patients. That's, none of us got into this field because we, wanted to, stigmatize folks with HIV or shame people for how many partners they had, things like that, right? Our intent certainly is good, but it is important to really analyze the impact that we have on our patients, particularly when we're trying to look through a trauma-informed lens, and to ensure that we really are providing the best care that we can for our patients. In my former role, or my role before I was with the Prevention Training Center, I was a director of testing, outreach, and sexual health programs in our youth division at Washington University. We looked really, really closely at what our words, what our language, what our actions, how those impacted the young folks that we work with. And it is it's shocking sometimes to see, and we'll talk about that a little bit further, when we really start to kind of look at some data. These are some, just kind of, again, going back to sort of some of the antiquated models. A bad reputation isn't all you get from sleeping around. Like another kind of classic sort of stigmatizing, a bit like fear-based sort of thing. And, we certainly have gotten better over the years. Respect yourself, protect yourself. We'll talk a little bit more about these. Like these are ones that, seem like we're on the right track here, right? Or my body, my risk, my rules. These are definitely going the right way. But as we talk more about, really what trauma-informed practices look like, and what we can do with, our marketing or, things like that within our agencies, we'll see how we can still continue to evolve here. I do find, I don't want to bore you all with lots of definitions in this talk today, but there are a few things that I think are really important to give sort of a baseline understanding of where this model of trauma-informed prevention and care kind of came from. And I love this definition of sexual health from the World Health Organization. And the few definitions that I have here, I am going to go ahead and read because I think that they're really important. Sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, and I like to read that line twice. It's not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable, and safe sexual experiences free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected and protected and fulfilled. So again, I love this definition. And one thing I want to talk about, and I'd like to point out, is the notion of safety. And for this trauma-informed model, one thing we talk about over and over and over, and one of the most discussed modules in the training is about language, but particularly the idea of safety. So when I refer to safety, it is situational. So does the person feel safe in their environment when they're having sex? Is it safe in that it's free of coercion, discrimination, and violence, not necessarily whether or not condoms are present. And I, as we talk more, I really encourage you to think about that notion of safety when you are interacting with your patients and clients. Next is trauma. It's the basis of what this training is all about, right? So it's an event or series of events and circumstances that have lasting adverse effects on someone. Okay, and this is Sampson's definition. So this is sort of the second part to that. When I think about trauma, I think about it in two ways. So we think about big T's. So, socially accepted traumas, war, car accidents, physical abuse, perhaps pandemics, Perhaps some people would put that under a little t. A little t is something that is less socially accepted. So, we think about body shaming, transphobia, homophobia, racism. Again, another one that I think could have places in both big and little t's. Slut shaming, HIV stigma, little t's that we may, even though we're working in sexual health, may not think about impact our patients and clients to the extent that it really does. So, a lot of what we talk about in this training pertains to little t's. So, I just really encourage you to also think about the little t's when we're interacting with our clients and patients. So these are the 6 tenets of the trauma-informed approach that we created: the do no harm, acceptance and transparency, peer support, collaboration and neutrality, community empowerment, and reflection. The ones in green are the ones that are most touched on in the training, although when we do the full 4 modules with folks, we do, of course, cover all of those. And we'll talk about them a little more as we go through here. When we were creating this training, these are some of the other models that we found for trauma-informed approaches. The one right behind me here is CDC's model. I really liked the one from Bridge Housing, which is a community building model for trauma-informed community building. The thing with these models, though, is that they're fairly linear, right? So when we look at them, there's it looks to be a beginning and an end. And when we created our model, we thought it's really important to recognize that trauma-informed care, trauma-informed prevention isn't linear, and our patients don't always operate on a linear sort of scale, right? So these are all things that are happening simultaneously. Sometimes we may see someone in sort of one one tenant, and then we need to kind of revisit another one with them. It's certainly fluid, and I don't want folks to feel like there's a beginning and an end. We're not going to start and finish trauma-informed prevention and care. We're going to continue that through our entire relationship with the patient and the client. So these are our 4 modules that are part of this technical assistance package. So the first one is quality improvement. The second is sexual health history taking. We have gender inclusive care and addressing racialized barriers. So, kind of going back a little bit to the need and sort of where these modules came from. When we first created this training, I would go to meetings, meeting after meeting after meeting, and talked till I was probably blue in the face about the need for a trauma-informed model. In interactions with colleagues, and thinking about what we have created and what I hear happening in some organizations was, it was sometimes troublesome. Sometimes I just knew that, it was a great example of why we need to innovate. And then we went to our St. Louis City Health Department, and they gave us their full support to do this training for their funded agencies. And then we took it to St. Louis County Health Department, and they recognized the importance of this training. Great, gave us support. We talked to the state health department, and they talked about incorporating it into their new tester training. And that's one thing that I think is important and innovative and exciting about this particular package is that it doesn't apply just to STI clinics, although I work largely with STI clinics, but we consulted and did training modules for pediatric clinics for one of our docs. This can be for new testers, this can be for your new staff. It doesn't have to be anyone just in an STI clinic. sort of the ideology of this training is far broader. And, also part of why we kind of have divided things into modules is because, I think it is, there's value and importance to highlighting each of these topics separately. One time I did this training, a trauma-informed training, and included a gender-inclusive care, for instance. So it was not kind of that module hadn't been separated out yet. And, we had some feedback from the staff that we are glad we had this training, but it really only affects 10% of our patient population. Now we need a training that's going to affect 90% of our population, because, I think, folks sort of felt like we got stuck on the gender inclusive care part of it, because that is something that's sort of, it's newer. It's sometimes difficult for folks to sort of, get on board with. And, the thing about trauma-informed, the sort of idea of being trauma-informed is that this does affect 100% of the people that we work with, 100% of our patients, 100% of our staff. When we think about being trauma-informed, what we're really saying is that, it's easy to assume that more folks than not have experienced some form of trauma, and the folks who we're seeing most likely have experienced some form of trauma, and as well as our staff, our practitioners alike. And, we really have to, move towards a trauma-informed sort of way of thinking to make sure that, again, we are including everyone and providing the best care that we can, both for our sort of external and internal clients. So let's talk a little more in depth about each of the modules here. So aside from trauma-informed care and prevention, quality improvement is one of my biggest passions. And I think so important for the baseline when we're doing any sort of training or any process that you're implementing. And it is sort of surprising to me how little we really know and understand about quality improvement. This quote has hung on my office wall for years. The most dangerous phrase in the language is we've always done it this way. And I think our prevention system is sort of an example of that. We've done prevention the same way for a long time, and it's tough to change, and it's tough when you feel like it's a huge system. How can I change it? Quality improvement is a really good way to start. So, we want to make sure that we are looking for ways to improve the quality and performance of our programs. And, I think for some organizations, it's difficult to think about how do you quantify trauma-informed care? How do we make sure that we're being successful with that? And there are some things, and we'll talk about some quantitative ways to analyze the impact of incorporating trauma-informed processes in your clinics, and some more qualitative pieces. It's important to remember that there's opportunity for improvement in every process in an organization. And this is, again, one of those things that's sometimes hard for us to think about. Like, we think that, we're doing a great job, and we are. It's a tough time. We're being pulled in a lot of directions. Sometimes, we don't have enough money, we don't have enough staff. How do we accomplish everything we want to get done? Or, we think we're just really excelling. We're meeting our metrics, we're seeing patients, et cetera, et cetera. But in every process, I promise you, we can find ways to improve. And this is systemic, it's objective, and data driven. So, we're not calling out the bad apples, like we would, like if we think sort of a mentality of quality assurance. Quality improvement is about really looking at our strengths and some of our deficits and working to make sure that we're doing the best work that we can. And we want to make sure that we're providing tools, right? So, requesting a training, requesting technical assistance, offering our time to our staffs. What can we do to make sure that we are facilitating change? Talk about in your staff meetings. What do we need? These are all things that are really important pieces of quality improvement. And why are we measuring things, right? Because we can't improve what we're not measuring. And I talked about this at the very beginning. It separates what you think is happening from what's really happening. Again, it's difficult to be objective sometimes when we're in the trenches doing the work, and we think that what we're doing is best for our patients and our clients. And sometimes we have to take a step back to understand like what's really going on. So, the whole quality improvement process is, it's absolutely necessary when we think about changing other pieces of our work or our processes or our policies or whatever it is. The next part, maybe the most important, start small and build. I think when we think about making changes, the reason change is so intimidating and scary for folks is because they think we have to change everything all at once. And quality improvement tells us otherwise. Start small. Incorporate trauma-informed processes or principles in a small way with maybe, on one form or during one clinic or with one department of your staff, and really see how that works. Look at the data before you just change everything. The other thing about quality improvement that I think is wonderful is that, if it fails, it's okay. That's what quality improvement is all about. And that's what these incremental changes that we make into our environments and our organizations are all about. If it fails, we change it. If it works, we roll it out further. So, whether it's thinking about, implementing trauma-informed processes and policies, whether it's thinking about incorporating a PrEP clinic, whether it's rapid start, whatever it is, we don't have to do it all across the board. We can start small and build. And I think that makes it a lot more manageable for folks to understand. So there's a question: is the use of prevention not trauma-informed, considering that could be triggering for someone being cared for and receiving care post-STI HIV diagnosis? Could that be an ongoing reminder of one's failure at prevention? Courtney, you are like the #1 student right now because we're going to talk about that soon. And yes, actually, so we'll talk about that here basically in the next module. So thank you for bringing that up. So the second module of this package, of this technical assistance package, is talking with folks about how to take a sexual health history. So we want to address internal biases and our comfort level. This is always a really fun part of the training because this is when people sort of talk about, I have an activity where people talk about sex and all kinds of sex, and it's awkward and funny, and that time to sort of like take an inventory of where we are in terms of how we provide sexual health services to our patients. But it's really important to being able to get to a place that we feel comfortable addressing things with our patients. Of course, incorporate trauma-informed principles. There are, a lot of things sort of from our model, and some sort of like subcategories. One of those being language, which we're going to talk about here really shortly, and that'll go back to your to your question. So we're going to determine our care approach, whether someone's symptomatic or asymptomatic. We want to address vulnerability. So we want to talk about, what makes someone more vulnerable to STIs or HIV, or why are they here, basically? What questions do you have? We want to provide education, etc. Now we want to mirror patient language and ask clarifying questions. This happens a lot. Like, we may have a trans person in our clinic who uses terms like front hole and back hole. And if we continue to use terms that may be medically accurate, but something that's out of their sort of like comfort level or wheelhouse, it could be traumatizing for someone. As providers, it's really important to be able to sort of like, what we always say, we want to meet our patients where they are, right? And it's important to think about that truly meeting where they are and not meeting where we are, where we want them to be. So, the more comfortable we can make them, the better. Discuss prevention needs and create sexual health goals with patients. So here's the first introduction to one of those language shifts and sort of shifts in what I think prevention should be. Prevention, remember, sexual health is not just the absence of disease, right? So we're not just preventing disease. We are here to provide, a full range of sexual health services to our patients. So my challenge to you is to start thinking about prevention in terms of sexual health goal setting. We have goals in every other realm of healthcare. We want people to quit smoking. We want people to eat better and lose weight. We want to make sure that we are doing things to control diabetes. We want to exercise more. We have lots and lots of goals in every other aspect of healthcare. We don't have that in sexual health as much. Sexual health goals are important because it's more than asking someone or telling someone they need to use condoms or have less partners, right? Like, there are sometimes things that our patients come in to see us that have issues that supersede the need or want to use condoms or whatever the case may be, right? So sexual health goal setting could be, not getting blackout drunk at a party that they go to or when they go out on a Saturday night, because sometimes folks make decisions that they wouldn't normally make. That's a sexual health goal that we can talk to them about. We can talk with our patients about how to talk to your partners. That's a sexual health goal. And things that are important to prevention, but again, are more than just things that we can do to help someone prevent disease or infection. So these, I always like to just kind of touch on the 4 R's here when we think about providing trauma-informed care or prevention services. So we want to be sure that we realize how widespread trauma is when we're talking with our patients. Again, it's easier to assume that someone in front of us has experienced trauma more often than not, right? So we want to recognize those signs and make sure that we're not doing things to re-traumatize folks. So, we can take all these tools and, make sure that we're doing what is right for that particular patient in front of us. I have folks that'll say, if I said my pronouns to my 70-year-old patient, they would think I'm crazy. Well, that's okay. Incorporating things like pronouns are important, and you can educate someone on that. Or, maybe it isn't for everyone, and that's fine. You can sort of, you know best how to interact with your patients. I always tell folks that we may be the expert in healthcare or their treatment, but our patients are the experts in their bodies and the experts in their trauma. People experience trauma in different ways, as we know from those little T's, and people respond to trauma in different ways. I can speak from my experience, and I use this example often. So I'm, a 41-year-old gay man, and when I was in my 20s, I basically disengaged from the prevention system. So I didn't want to go get tested. I didn't want to, talk to my doctor about sex. I didn't want to do any of that because I felt shamed and I felt guilty, because what happened was that basically, because of the kind of sex I had, I became a risk factor. I became a high risk person. And I didn't want to hear that when I went to the doctor. Like that wasn't what I was there to have them tell me, that, I'm having risky sex or, whatever that was. I was there to, looking back, have someone help me with some sexual health goals. And whether that is prevention for someone, or whether that's, engaging in a regular testing sort of a routine, it means a lot of things to a lot of folks. Sex positivity is really important. And sometimes folks ask me, isn't this presentation that you're doing the same as sex positivity? Well, it's not, because when we're thinking about trauma-informed practices, we want to make sure that we are thinking about trauma that occurred with someone previously, and that we're not re-traumatizing someone. Sex positivity is certainly part of that, because we want to be accepting of all kinds of sexuality, and so sex positivity is certainly part of it, and I hope that we can incorporate the two. So this is a piece that typically has the most discussion when we start talking about language shifts. So we did touch already on prevention, right? So sexual health goal setting, again, meeting people where they are. Safety is a big one. Sexual health and well-being is what I talk about in this training, or empowerment. We talk about pleasure and consent when we talk about safety as well. When you look at the sort of meaning behind words that we use all the time, again, our intent isn't to re-traumatize someone or make them feel stigmatized, but the impact of our language with the folks that we work with can have those lasting effects, regardless of our intent. So, really thinking about and talking about the impact of the language that we use is important, and it's hard. So transmit, we talk about, instead of HIV transmission, we talk about HIV acquisition. What can I do if, not getting HIV or not getting an STI is one of your sexual health goals? How can I help you to not acquire HIV? How can I help you, not have somebody transmit HIV to you? Because again, that's sort of, it sort of reinforces that stigma around HIV, particularly for folks living with HIV. Risk, this is a really big one for me. I think, and maybe it's because the word risk was a trauma trigger for me as a younger person, kind of making my way through this system. I talk to folks, we address their susceptibility, their sensitivity, vulnerability. Likelihood is a great word that we use a lot. And we think about sexual self-efficacy. So, again, like goes hand in hand with sexual health goal setting. Non-compliance is a big one also. So when we talk to folks about PrEP or rapid start, or just antiretroviral therapy in general, we'll say, we often hear people say, oh, they're non-compliant, or they're not going to be adherent, or they haven't been adherent. Let's turn that around and talk about ability. Are you able to take a daily medication? What can I do to make sure that you're going to be successful in taking this? Because I assure you that when we kind of impart our judgment on some of our patients, we will be proven wrong. I always tell the story of a client that we had when I was an HIV case manager, who folks did not think would be compliant with their HIV medication regimen. And this person, the person was homeless. They were using drugs, and they were sporadic in coming to appointments. This person also took public transportation. We have a Metrolink. It's called the Metrolink in St. Louis. It's our light rail system. And this person would take the Metrolink to our stop every day, where they buried their medicine so that they could take their meds. And it changed my outlook 100% when I found out that every day, this person that nobody ever thought would be compliant is riding the Metrolink and burying their medication just so that they can make sure that they do it. So, you know, talking about ability and not that sort of like non-compliance or non-adherence is really important in language shows. We look at forms when we do this training. So what can we do to make our forms better? This is something that's client facing that I think is an easy change that you know, people often forget. Or we change our forms and we don't change our EMRs. And that's difficult for, you know, for our staff. You know, this is actually a form that we used to use on the adolescent side when I was working there. And we had made some, I think, great changes. So we changed things from like MTF or FTM to trans female, trans male. We have non-binary folks included. However, because of the way we report things, the back end or our EMR still has all the other kind of old, outdated language included in it. And I think that's really difficult for our you know, employees to see. So trauma-informed practices don't stop with our patients and our clients. You know, again, we need to recognize the importance of trauma and how it affects our staff and our employees as well. So advocating for changes, you know, on the backside of things is equally as important as the kind of client-facing pieces. Sexual self-efficacy. This is one of the pieces that I think is great for folks who are like, we need quantifiable data on how trauma-informed practices work with our patients. This is a sexual self-efficacy scale that we used in our prep clinic, started in our prep clinic and eventually rolled out further. But it has 4 quadrants. So it's a survey, it's a quick sort of survey that you can do with any patient or client when you're taking a sexual health history or at any other visit. But it asks questions that pertain to power, pleasure, protection, and intimacy. So, you know, can you tell your partner to stop doing something that doesn't feel good? Can you talk to your partner about testing? Can you have an orgasm? Can you speak your feelings? Lots and lots of different things. Masturbation, talks about a whole gamut of things that I think sometimes are difficult for people to talk about with their patients and clients. But when you plot their answers out on this graph, it's amazing to see. Again, we were using this with our prep clinic. So we were able to see, as someone was on prep for longer periods of time, where they fell in terms of the scale. You know, is their pleasure increasing since they've been on prep? Is their intimacy increasing? Do they, you know, again, we'll probably change this word from protection in here, but like, do they feel more protected or whatever that means to them? So it's really, really exciting to find something in sexual health other than your positivity rate that can indicate success and you know, the satisfaction of the patients and clients that you're working with. So the next module is gender affirming care. So when we talk about gender affirming care in our training, you know, we kind of look at it through these 4 sort of buckets. So social, like their names and pronouns, psychological, medical, and legal. And so we talk about these, you know, semi-in-depth through the training. And again, when we get to gender affirming care, there typically seem to be the most questions, the most discussion. sometimes the most opposition, because these are things that are still new to folks, and it's difficult for people to understand. So, why does this matter? Why does gender affirming care matter? And why is it such an important piece of this training? LGBTQ youth are 2 to 3 times more likely to attempt suicide. LGBT folks have the highest rates of tobacco, alcohol, and other drug use. Lesbians are less likely to get preventative services for cancers. All of these things are indicators on why it is so important that we take into consideration a trauma that may come with some of our patients, and we do everything that we can to combat that and to kind of help someone move forward from that and make sure that they feel safe in our space. Again, the language piece is a theme throughout the entire training. So, we talk about ways to say, just give people sort of ways to say things in a more trauma-informed way. Another one here, maybe these are some things that you all are doing, some things you've thought about. Why aren't you using protection? It's okay to have condomless sex. And this is a big one when we're talking about back to the kind of sexual health history taking. I used to challenge my prevention staff. What do you do if someone says they don't want to be on PrEP and they don't want to use condoms? And there's always crickets. No one knew what to say. And that was a problem, because we should be able to have sexual health conversations, and we can still set sexual health goals with folks, even if they don't want to be on PrEP and they don't want to use condoms. And that's not to say, I'm not saying that nobody needs to use condoms or no one needs to be on PrEP. We know that those are important things, right? But we have to be okay, again, meeting someone where they are, truly, and being able to work with them from that starting point on. This is the 4th section talking about addressing racialized barriers. So we cover institutional racism, medical mistrust, again, language. This module is one of the modules that was kind of that kind of came out of we want more specialized or specific training to for the Black and brown folks in our clinics. And so we thought about what does that really mean, and we want to make sure, just like any other population that we prioritize, that we know maybe marginalized, we want to make sure that we are equitably providing care and attention to those folks in our clinics. So this module is the newest, and it's actually really exciting for me. So we start talking about cultural humility. It's a lifelong process. We talk about addressing power and the power dynamics of our patients and providers. Again, this is kind of one of those topics that becomes kind of difficult for people to think about in their clinics. Like we all think that we don't have power dynamics in our clinics. We don't have power dynamics in our offices. Most of the time we do, and when we do sort of that needs and gaps assessment, or we talk about really looking critically at the services we provide and how we provide them. Again, it's difficult for us to think about, but some of the processes that we have in place in our clinics can certainly be trauma inciting for our clients. And those are those things that we can change and we can monitor and we can make better. Developing partnerships with communities that may have individual defined populations, and advocating. These pieces of cultural humility or cultural responsiveness, I often say, are integral to providing the best care that we can for the folks coming into our clinics. We know that trauma-informed care, trauma-informed prevention are grounded in equity. So, are we making sure we're giving everyone what they need to succeed? Why I like this, the context for why the needs of different communities are different is essential. What my former clinic provided and who they provided services to could be very different from a clinic in New York or a clinic in Mississippi or a clinic in Washington or Idaho. Really looking at the context to make sure that we are being equitable is important, because we, I think we want to make sure that we're treating everyone equally. And sometimes, we have to kind of check ourselves within our processes and make sure that we're treating everyone equitably. Any questions so far? No? Let's see. Again, talking about power and privilege. This is a tough one, particularly when we have, when we have folks in a room who, obviously may be in places of power and or privilege. It's tough. This is one of those conversations that, we have to remind folks this is a safe place, and a place that we address trauma not just with our patients but within ourselves and within our staff. Being able to do that is a really important part of providing the best care and being innovative with our services. I think that it probably isn't happening a lot in a lot of agencies that we can have discussions about power and privilege within our organizations. And it is, however, very, very important. Practical application. So this is a piece of our model of our module on addressing racialized barriers. It's an actual activity, but is certainly a theme in the other modules. So we really look at these sort of 5 areas. This is sort of what we thought were the most sort of important or obvious places where we can apply trauma-informed principles. So what does it look like in our front desk and our phones, our forms and our EMRs, provider interaction, lab, and coworkers? Again, we don't have to change our policies all across the board. We don't have to change our policies, our principles, or in every single one of these areas. But we can do it slowly, and we can do it incrementally, and we can become more trauma informed, on a small scale before we kind of blow that up to our whole agency. But this is a really interesting exercise that we do because we ask people to look at each of these areas and talk about how or what we can do to be more trauma informed in each area. And this is one of the ways that I think this training and this technical assistance package has grown over the years, is that there are things that I never would have thought of when we first created this that people have pointed out as we've done the trainings, and we've been able to incorporate that. And I think whether that is whether we're training this organization or I'm looking at ways to customize it for the organization, it's really important to take those things into account and make sure that we're being fluid to be sure we're giving everyone what they need with this training. So that's kind of the overview of the 4 modules. Does anyone have any questions, comments, debates about some of the trauma-informed principles? Anything at the moment? Okay. If you think of anything, just again, go ahead and pop that in the Q&A. I just want to talk a little bit about training, what's technical assistance, and what we can do to help you and your organization. So when I think about training, I think about it as a sort of large systems approach. So we usually have a big group training, sometimes small groups, but it basically is an overview of a topic. So, somebody contacts us and requested a training on trauma-informed care prevention. So we, do sort of an overview, or somebody wants to know about PrEP, starting a PrEP clinic. They are, group settings that lead to technical assistance oftentimes. So technical assistance can be looked at in a couple of different ways. So indirect or direct. And when we talk about technical assistance, we're thinking about targeted support. So, we've talked about needs, we've looked at a needs and gaps assessment, or we've talked to folks in a organization, and we know that we really feel strongly that we want our team to have the tools to be more trauma informed. So let's do these 4 modules, for instance, with our team, and that would be direct technical assistance. So we're coming in, we've found the need or the issue, and we're going to help you address that. Indirect is providing resources. So you may ask me for, some information on PrEP, and I send that to you. So that could be an indirect sort of way of providing technical assistance. Some of the outcomes and benefits, like, is it worth it? Is being trauma informed really that important for how we interact with patients and clients? And I promise you, you will see increased patient satisfaction if you do patient satisfaction surveys. We certainly saw an increase when we completed those with the folks like in our PrEP program and our prevention case management programs. When we did that. I had not seen the results from our larger patient satisfaction survey, but I've had people, like someone in the opening video, someone said, I've never told anyone this. When I used to participate in our testing team, when I managed our testing team, I still tested once a week because I wanted to make sure that we were implementing these processes, and I wanted to make sure it was working. So, all the time, I cannot tell you how often somebody said, I've never told anyone this, or my doctor, I could never talk about this with my doctor, or, thank you for this information. We talk about things in trauma-informed ways, and it makes people comfortable. It helps improve their health outcomes. It gives them an enhanced sense of self-efficacy. So they, our patients are going to be more able to advocate for themselves. They'll be able to tell their partners what they want, what kind of sex they want to have. Things that I think, us just telling them they have to use condoms all the time and be on PrEP, they're going to get a lot more richer conversations and richer relationships with you as a provider or a case manager or DIS staff or whatever it is, and feel comfortable. I also, another very sort of quantitative way that we were able to, look at whether or how this is working, referral sources. Our word of mouth referral sources drastically increased when we started implementing trauma-informed practices. When you have patients who are saying to their friends, I don't want people to come. When I was working in our adolescence, I don't want people to come because it's the only free place to come for adolescents, right? Like, I want them to come because they know they're getting the best care and they feel comfortable in the environment, and they feel safe, and they want to come here, not that they have to. These trauma-informed principles across the board are helping people feel better. When we can kind of leave out some of our judgment and really sort of work with people where they are. It's important. One of our doctors at the PTC often tells a story about getting tested. And when the tester asked them about how many partners they had, they said, oh, well, we're going to have to bring that down. Well, you know what? It's not my job to tell you to have less partners. And it certainly isn't very trauma informed. I always tell people that when I was testing, particularly or client facing, is that my job is to make sure you're having the kind of sex you want to have with whom you want to have as often as you want to have it. And align that with sexual health goals that you set for yourself. So, these relationships that form because we're implementing trauma-informed practices are really very important. And of course, we've seen a decline in reinfection. So our prevention case management program that we used to have, the folks who came in met with a prevention case manager because they had an STI, versus folks who came in, got treated, and never met with a prevention case management were drastically different. We had far less people coming back in with reinfections who met with our prevention case management staff and had some of these sort of trauma-informed principles in sexual health discussions. So just a little bit of some of the outcomes and benefits. So we talked earlier a bit about how the PTCs provide training and technical assistance, and this is where you can request that. So let me move out of the way here. If you go to www.stdccn.org, you can fill out this form here, put in your questions, your training requests, your technical assistance requests, and this will route your request to the closest prevention training center to you. We get these requests and questions and we answer them within a couple days, but there is a place, like if you have an urgent question, you can ask for an expedited answer as well. So if you feel like you want to know more about this training, for instance, our trauma-informed training, send us a request. This will route it to us. If you have other questions or other trainings that you feel like you need, send those to us, or send them to your, put them in here and send them to your local prevention training center. And then I think this is the last slide. It sure is. We've come to the end. So this is my email. If you have specific questions regarding this training or bringing it to your organization, again, we at St. Louis PTC have 6 states: Missouri, Illinois, Kansas, Iowa, Nebraska, and Wisconsin. But our hope is that the more I can talk about the importance of trauma-informed practices, the more I can talk about this trauma-informed training, the further we can expand it to organizations outside of our PTC coverage area. So I welcome you to email me, and let's get this training out to you guys. And then of course our website, preventiontraining.worcester.edu. And I thank you very much for having me today. It's a pleasure, and really, really cool to see all the great work everybody else is doing out there. So thank you very much.
Thank you so much, Jeremy. And if you have any questions for Jeremy, please feel free to put them in the chat or the Q&A. Jeremy, I have a question. So how would you advise someone who works at a sexual health clinic who says, listen, we know that trauma-informed care is important, and they're trying to convince their boss. I think trauma-informed care gets thrown around quite a bit now, and I think it means different things to different people. So if someone said, I really think we should be a trauma-informed clinic, and the boss says, we did a webinar, we're good. Like we did a half-a-day training, like we've got it. How would you advise them to approach that conversation and say, there's more to this? How would you how can they kind of back up that argument?
Well, first thing I would say, they're off to a great start. Certainly, praising someone for the interest and recognizing that we or they do need to be more trauma-informed is the best first step. The next part is that implementing trauma-informed principles into your clinic costs nothing. Changing your language is free, right? Sometimes when we look at starting to like build out our EMRs and things like that, may be different, or depending on the size of the organization, changing a form, like being able to add pronouns to your forms, or being inclusive of gender diverse populations on your intake forms. These are things that don't typically cost a lot of money. They're easy changes to make, but the impact is really, really big, right? So, I would just encourage folks to ask their organizations to have conversations about this in their staff meetings, or contact their PTC. The St. Louis PTC is happy to talk about it all the time. Like, I can talk about trauma-informed practices until I'm blue in the face. I just think that there are a lot of things that we want that typically require money, like, oh, I need a van to do outreach, or I need to create a marketing program, or I need to do whatever. But the idea of being more trauma-informed doesn't cost anything, and we can all do it. We can do it in our direct contact with patients or clients. We can do it one-on-one with our coworkers. You can certainly start on a very, very small scale before we really change the entire prevention system, which is of course what I hope we can do. But I would just say start small. And if your organization says, oh, we can't afford to bring Jeremy in to do this training, or we don't have the time, whatever, start with your practice. Start with your interaction you have with a client or a patient, or whatever that looks like, and see what can snowball from there.
That's very helpful. Thank you.
Mm-hmm.
Just double checking the Q&A. How do we even introduce this trauma-informed care training to clinics as an outsider? If I'm a patient who's had a poor experience, where I can go to put pressure on the clinic to do better besides just not coming back there for services?
That is a great question. I think it is difficult sometimes to find the right person or the in, right? I think that it never hurts to send an email to the organization, to the provider, to the office. I also don't think that it is out of the question to, if you're here on this talk, like, contact your prevention training center. You have that STD-CCN site now also. And while it's certainly less common for a patient or a client to request a thing there, I'm always happy to reach out to folks. And I think that, we can figure out a way, to, particularly if it's someone in our sort of jurisdiction, like, you have a clinic in St. Louis that you had a terrible experience with, maybe it's not the clinic's fault. Maybe it's our region's fault because we haven't offered this training. And I can send out a blast to our region to say, you know what, we have this training and I would love to do it. Be creative and let your voice be heard. And, I'll be a resource. So, yeah, but don't be afraid just to send something directly. I know it sometimes feels like it falls on deaf ears, but we'll get you hooked up. Save my email.
Thank you so much. And so can people contact you if they have any questions or would love to follow up? Okay.
Absolutely. Yeah. Send me an email directly.
Great. Thank you so much. We'll be sending out your contact information when we send the recordings and the slides. So thank you again, Jeremy. What a wonderful presentation. And I know we'll be hearing from you again soon. Take care.
Bye.
Bye. Well, everyone, we made it. This is the end of the inaugural Clinic Plus Connect Community Conference. I'd like to thank all of my incredible NCSD colleagues, including Dr. Chris Hall, Michael Canty, Talia Parker, Aaron Fratto, Amanda Dennison, Iman Carnaby, and David Harvey. Thank you so much to all of our incredible speakers, presenters, and panelists. And above all, thank you so much to each and every one of you. You are the heart and soul of our Clinic Plus community, and we wouldn't have these incredible opportunities if it weren't for you and your fearless dedication to providing sexual health services across the country against seemingly insurmountable challenges. In the next week, you'll receive an email with materials from the conference, including slides and recordings. The email will also contain a survey about the conference. I encourage you to please complete the survey and enter your mailing address information so that we can ensure you receive your gift bag if you are one of the first 500 registrants. I also encourage you to connect. Please reach out, connect on MyNCSD, email us, set up a meet and greet. We'd love to learn more about each other and learn what resources would be helpful to you. Thanks again. We hope that you continue to join us as we elevate the voices of sexual health clinics across the country. Take care, everyone, and we hope to connect with you soon.